Monday, March 24th, Minnesota Human Services Committee. We have a number of bills in front of us, members, and so people that are testifying on other bills, I would ask that you please just get to the topic at hand, especially because, you know, folks, and I'll do that when there's some other ones that come up, that we've been having a conversation, this committee. So please be to the point, and we would appreciate that. And we do have an ongoing conversation. Senator Rasmusson, the county cost modification of care provisions, when we talked about it, it was like we were once again up against that timeline. So thank you for coming back. And then I also have somewhere along the way, the Attorney General is in our presence, Keith Ellison, and we would like to bring him up to also have a conversation with you. And Keith talked a little bit, you and the Attorney General talked a little bit at the end. So Senator Rasmusson, take us where we left off on Wednesday.
Thank you, Mr. Chair. I appreciate the opportunity again to continue the conversation on Senate File 2628. And, you know, we had the opportunity last time we met to present the bill and to hear from a number of testifiers. I do, Mr. Chair, have an amendment that I'd like to move. So I'd like to move the A1, and I'm happy to describe the amendment.
Yeah, it's your author's amendment, Mr. Senator Rasmusson, correct?
Yes, this is an author's amendment, and it simply would put in a provision that would allow the Commissioner of Human Services or designee to immediately approve an exception to add up to 10 patients per fiscal year who have been civilly committed and are in hospital settings. And so this is at the request of the Minnesota Hospital Association, and they believe it'll help them get people in the appropriate care setting.
Members, Senator Rasmusson's A1 amendment, all those in favor say aye. Aye. Opposed, same sign. Senator Rasmusson, now the bill is in the order that you wanted, so take care.
Thank you, Mr. Chair. And with that, I don't have any more comments than what I said last week, and so happy to hear from the Attorney General or to take any member questions.
Awesome. Members, do you want to bring the Attorney General up first and then go to questions, or do you guys have some questions now? We just lost a bunch of people, Glenn. Where'd they go to? Did you chase them out?
I sat down, they just
Oh my God, that's funny. Attorney General Keith Ellison, please. And Attorney General, welcome to the committee. Just to let you know that this bill is what we're going to probably do is re-refer it to state and local government, so the conversation continues. It eventually work its way back here. So with that, Attorney General Keith Ellison, the mic is yours.
Mr. Chairman, thank you. And also, Senator, let me thank you for your care, concern, and interest in this very critical issue. As members know, I served as co-chair of the Priority Admissions Task Force, which was enacted per legislation. And this is very important to note that because, you know, this legislative body is well aware of the challenges associated with this issue. What we learned and what we found is that this issue is extremely complicated. If you squeeze one part of the system, it will put intense amount of pressure on some other part of the system. So I believe, and this is my own take, is that we have got to have a systematic approach to fixing this problem. Yes, it starts in our emergency rooms and in our jails, but then we want to get people into DCT as fast as we can, but then you got to get people out of DCT, and that means you need community resources. And we simply don't have the capacity that we need. The answer is, in part, I believe, more beds, but more beds also means more trained staff, and that is not a short-term solution, right? And then you need community resources, and then not everybody needs to go into the DCT, particularly if you can treat them. I guess that's what I mean by it's a complicated issue which requires a care at each part, at each link of the chain. After 2 years of hard work and conversations, the task force issued 2 reports which set solutions out that can help Minnesotans begin to tackle this issue. The recommendations were a consensus of the task force members. No one got exactly what they wanted, but there was agreement that these were recommendations that everyone on the task force. I'm not aware of the bill and haven't been notified about it, but I can tell you it's not intended, and I've been assured by my friends and colleagues who work at the county level that it's not meant to be a task force bill, but it will impact what we're doing. It will impact the issue. And I sympathize with the counties. Everyone wants to ensure that people receive appropriate services in the appropriate setting. And there's no doubt that not being able to move folks to AMR, TC, for example, in a timely manner is a huge burden on the county staff, county budgets, and this has to be considered. This strain on county, and as was pointed out to me a minute ago, actually on taxpayers, where it ultimately lands. But I will say that, and I want members to know, if you don't know, and maybe you already do know, that Minnesota has the shortest timeline in the country. And research presented to the task force showed that almost every state had issues meeting their timelines, which are longer than ours. SF 2628 is important because it does help relieve pressure on counties, but I fear that it might put pressure on every other part of the system. I would say that I can assure you, as Attorney General, that removing the language, medically appropriate bed language, will just mean we're going to get sued more because we don't have the capacity. And we'll have judges threatening contempt motions. Those things will happen. We need more beds, but we also need more staff. We need more beds, but we need more community solutions so folks in the system have a place to go to. And the state needs a systematic solution, including workable timeline for moving people from community into the appropriate setting. I do fear that bringing the state back to what was current law 2 years ago, 48 hours to move someone, I don't think we're going to be able to achieve that goal in a realistic timeline, and I think that's going to mean lawsuits, and I think it's going to mean we're not going to serve people who have disabilities who need to be moved forward. But I will say this to you, Mr. Chairman, and I'll say this to you as the author of our bill. I am 100% dedicated to working with you and anybody else to solve this problem. People in a mental health crisis need help, and we all should be sensitive to that. So that's all I wanted to share with you, and I want to say that this is a tough issue, but I'm glad that this committee is not afraid to take it on.
Thank you, Attorney General. Thank you, and I thank you for your leadership in doing that. It was the first time, I think, in the history that, if you talk to Kevin Magnuson, and he's in this room, I mean, if he wants to come on down and have a chat about that process that we put in place was like the first time in history where the Department of Human Services, and I know Dr. Kylie Ann Stevens, and you toured. You did a Hennepin County, Anoka County. You came out there.
Sure did.
And that's something that's there. And what makes it tough is when we start to talk about the needs, and not just bed space, but I know this committee we talked about is 351 beds that are there that are available. We still have a problem even in the civil commitment side, and I know Attorney General Ellison that you're working with Senator Ron Latz on a civil commitment piece, which I think Rasmusson, you might be a co-author of that too. I think, or Utke, somebody from this committee is on that Ron Latz bill. You're on one of them, and so we're on the same. It's the same dialogue, and I know Senator Abeler also has some language that he's bringing forward too. So thank you for your willingness to work with our committee. And then we talk about our committee. It is our committee. I mean, the work we do here is in a collective manner because we only care about what we do and the best thing that we can. We're keeping focused on the end result there. So I don't know, Magnuson, if you wanted to come up and kind of talk about that process too, Jordan or Senator Rasmusson, if that's your, but if you want to stick around, Senator Utke's got a question.
Yeah, thank you, Mr. Chair, and we can go forward, or I do have a question with a couple of things the Attorney General said, and just for clarity, it was mentioned a couple different times, we will need community resources and community solutions.
Right.
I would like you to elaborate a little bit on the community resources. I mean, that could be money, it could be facilities, it could be a lot of things, and I think we should clarify.
Attorney General, thank you, Senator Utke, for bringing that, because we're sitting there going, if one part of the system, for example, we're going to be putting, not cutting services, I'm just capping, capping the increase and stuff. But Attorney General, please answer.
Yeah, Mr. Chairman, all I really mean by that is, once you get somebody in DCT, you got to get them out, and just because they're not suitable for DCT doesn't mean they're suitable for everyday life. And so some sort of a step down, system, less confined, but still services. And what I would say, Senator, is I would leave the detail to people who are mental health experts. I've had a number of conversations about what those look like, some sort of I don't know, anything from a group home setting to various other ones. I'm not a psychologist or a professional in the area, but I have been in dialogue with people who've assured me that part of the problem is not just a bottleneck in the front of the system, but also in the back, getting people out of DCT so they can go to a suitable new place to be. Does that answer your question well enough?
Senator Uckey.
Thank you, Mr. Chair. Yeah, that's exactly because, whether it's coming out of DCT or out of even just our hospitals nowadays where somebody with mental health got into the hospital and they have nowhere to go, it is that off-ramp. What is that next facility that gets them, because they still need more treatment, not the severe heavy-duty treatment, but they got to go through the phases to get back into regular life in the community. So, okay, it could mean a lot of things, but we're on the same page there, so thank you.
Absolutely.
Thank you, Senator Uckey. Good senator from Glencoe, Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah. I'm new to this committee this year, to HS in the Senate, but when I was in the other body, I was on HHS for quite a while.
Were you on education too?
No, yeah, I was in education over there too.
I love that.
I was on the school board for 16 years. You remember that? But the thing I consistently heard is that it would be less expensive and more effective to put them into additional beds than to keep them in our jails and our hospitals. And I know you have a workforce shortage and those types of things, but is there any plans? I haven't seen anything in bonding, or when's the last time we expanded beds for people in this situation?
Senator Rasmusson.
Thank you, Mr. Chair, and thank you for the question, Senator Gruenhagen. And I think, from everyone at this table, and I think on the committee, I think we all agree that the status quo isn't working. And what I mean by that is, we have individuals, I had one from the area that I represent who waited in a jail cell for 100 days, shouldn't have been in a jail, should have been under the care of direct care and treatment, but they're waiting for a bed to open up. And I think many people have these stories, and whether it's the counties or the Attorney General's office or direct care and treatment, I think everyone looks at that and says, this isn't how it's supposed to be. But one of the challenges that we have, and I think why I think this bill is an important conversation starter, is that from the governor's budget proposal, we see no capacity increases. They're asking for an operating adjustment to try to fill openings that they have, but we haven't seen a robust plan come out of the governor's office to say, we're going to try to work towards increasing capacity at direct care and treatment in a meaningful way.
Yeah.
And one of the challenges that I have is come July 1, the 48-hour rule is back.
Yep.
That's the status quo. If this legislature does nothing, 48-hour rule comes back July 1. And while I understand the desire to go back to the medically appropriate beds, and maybe that does become part of some solution to, along with increasing capacity, is that it effectively isn't really a deadline at all. Because what will end up happening is direct care and treatment can say, well, there aren't medically appropriate beds available, and it doesn't look like there's going to be one for the foreseeable future. And so medically appropriate beds could be that 100 days. It could be more than that. And so I think we all understand that there needs to be a capacity increase at direct care and treatment, and the status quo isn't working, and the real debate is what's the best way to get there. And I think it's going to take a lot of different solutions, not just this bill before the committee, but a lot of other work to over time. It's not just going to get solved in one session to try to get ahead of this problem that right now we're behind on.
Thank you for that, Senator Gruenhagen. Thank you for that question. Do you have a follow-up to that, or was that Senator Gruenhagen? Go ahead on follow-up to Jordan.
Oh, thank you, Mr. Chair. Yeah, I just remember in the Reagan years, it dates me a little bit, but we were actually closing facilities, if I remember right, in this across the nation and also in the state of Minnesota. Are any of those facilities available for upgrades that might help alleviate some of the bottleneck here?
Senator Rasmusson, to that, you talk about that, he privatized, he closed with the intent, this dates me too, Glenn. The president from California said he was going to increase community support services, and he never did. And so you start to see, this is when the conversation about who are the homeless that we have, and the Wilder Foundation and that study report, it shows, 90% have some intersectionality going on, whether it be intellectual disabilities, developmental disabilities, et cetera, et cetera. I think of one building, we asked that question in this committee about Cambridge, right? And I think there was the old buildings there, but I know in Jordan's backyard, in Senator Rasmussen's backyard, you have Fergus. I don't know, Senator, have you, looked into that? Because also in this committee, Attorney General Ellison and Kevin, it'd be nice to get Kylie Stevens or Dan Storkamp to come on down, and I got enough chairs up there. Maybe they can also have this conversation, and if we need to make more room, we can. But, thoughts on that, Senator?
Yeah, thank you, Mr. Chair, and thank you, Senator Gruenhagen. And yes, Fergus Falls is home to one of those closed state hospitals. I think, in the bill before the committee, there is a capacity increase. And I know if you look at the Miller building, for an example, at AMRTC, that is something where if we made investment, both capital investment but also operating investment, it's my understanding that could increase capacity for direct care and treatment at that critical facility. And so I don't know if the direct care and treatment team can provide opportunity, discussion on that. And I also know different communities, whether it's Clay County, Otter Tail County, others have raised their hand and said, for some of the lower acuity settings, that they're interested in trying to engage and help add in capacity as well. So I don't know if anyone else wants to add anything to that conversation.
And then, Glenn, if you're good, we'll finish this question and go to EMQ, or do you want to?
I got one more question.
You want to ask it in addition to this? You want to wait till this is done? Go ahead, Glenn.
Yeah. Well, what I was going to say is there any study that has been done that contrasts the cost of prisons or jails and hospitals versus opening up a closed facility, if that would meet regulations?
Senator Rasmussen, what do you think?
Mr. Chair, Senator Gruenhagen, I don't know of any specific studies, and maybe the professionals from direct care and treatment can offer some guidance on that. The one thing I will say, what I hear is when you have someone who is has a severe mental illness and they're in a secluded jail cell, that's not conducive to helping them become independent again. And so I think, again, that's what I hear from the parents, that's what I hear from the county sheriffs, the county attorneys, is that is not conducive to improving their situation. And the quicker we can get them into the appropriate care setting, the better for them and for everyone else involved.
And maybe it's a good segue to go to Dr. Stevens on this. She toured Mr. Ellison, Attorney General Ellison, sorry about that. The Anoka County, there was the gentleman right in downtown Anoka, and he spent 23 hours in that. His bed was on the floor. To that point, it was not therapeutic. Brad Weiss, I heard the sheriff say, this is not therapeutic. This is not getting to the needs of the individual that's there, and that was this group's commitment. So, Dr. Stevens, to that conversation that you're hearing, what are your thoughts?
Thank you, Mr. Chair. Okay, get this worked out here. Thank you, sir. Mr. Chair, members of the committee, Kylie Ann Stevens, Direct Care and Treatment. I would go beyond that to say it is heartbreaking to see someone in those situations for 23 hours a day. And I don't know how anyone can be unaffected by seeing somebody in a state like that. I think in terms of cost, for care, specific care, it is clear that acute hospital beds are the most expensive resource. And if you think of AMRTC as the intensive care unit of behavioral health in Minnesota, intensive care units don't run cheaply, right? Because there's a lot of regulations, there's a lot of staff, you get a one-to-one nurse. It's very similar in that way, not that everyone gets a one-to-one nurse. But if we're going to build those beds, and that is where the need is, at the highest level of care, hospital level of care, and secure forensic beds, those are very expensive beds. So that's why the community resources that A.G. Ellison and others have talked about are really important as step downs. But in terms of trying to cut costs or cut corners in building beds for DCT, that primarily the hospital level of bed and the acute care level of bed is what is needed, and those are quite expensive.
And that's, Glenn has a follow-up, and then we got to go to EMQ, and then I wanted to hear from Kevin on this stuff too. So-
Okay, yeah, thank you, Mr. Chair. Yeah, I know there's facilities that, like Appleton, that was, I think, a brand-new prison that we're not using out there, but, so that's kind of why I asked the question. The other thing, Mr. Chair, I would push back a little bit on the Reagan comment. He had to work with primarily a Democratic Congress. That's probably why he didn't fulfill his promise.
Mr. Chair, can I make an observation, Mr. Chair?
Oh, yeah, he's just beating on me, so you go ahead, Keith.
Mr. Chair, I just want to say, yes, part of the solution is, in my opinion, more beds. But understand, you got to have trained professionals to go with those beds. So when we talk about opening up new facilities, I don't think the biggest part of this problem is that we don't have buildings. The biggest part is that we got to have the people. Yeah.
Kevin.
Thank you, Mr. Chair, Senators. First, I don't think you're exaggerating when you say that this was a moment in time when things really did come together, when people saw the jails and the hospitals and this group that is the task force came together, and it worked really hard to expand each other's horizons, I think. I think it was difficult for the county folks to sit down with DHS and talk about, okay, how do we get some practical solutions? We're trying to get in a situation where we get the commissioner of DHS to ask our boss for more money to build capacity and hire people so that we can alleviate the problems in the jails. I mean, that's the fundamental issue that we're dealing with. And it was former Commissioner Harpstead and Attorney General Ellison who were the ones who pushed the linchpin of this deal through our group, who really rallied us around and said, okay, we need to focus on this idea of there needs to be capacity. If there's capacity, then we can talk about changing the deadline. But we need to add capacity to DCT, and then we can talk about some time period that gives DCT the opportunity to catch up on the need. So I think that's really important, and I'm very grateful to the leadership of both of them for that. Any changes to this this bill, I think need to focus on that link between capacity and other changes, but also, we've talked about the transparency issue that's really important. We've talked about the need to give notice to the individuals, and that's really important. We can work out some of the details, but there needs to be some information shared with the individuals, and we've had some discussion with people who have suffered for a long period of time without knowing that. I think without question, the most important part of this legislation is trying to identify the 20% increase in AMRTC, forensic, and HCBSs that is necessary to accommodate these increases that we've talked about. And that was in the task force report last year, then it was in the panel report.
Yeah.
And we're looking to see those kind of changes.
Mm-hmm. Thank you. Senator Maye Quade.
Thank you, Mr. Chair. I think this question is for anybody who is on the speaker panel up there who was part of the task force, the priority review admissions. Was there an agreement to keep the 48 hours from medically appropriate bed? Was there an agreement to keep that?
Attorney General, Dr. Stevens, Kevin, you got Senator, Commissioner Clark, so Attorney General.
Well, so here's the thing. The bill proposed is not represented to be the thinking of the task force. I think I could say without much fear of contradiction that the appropriate available bed language was in the task force report. Does that answer your question, Senator?
Senator Maye Quade.
Thank you, Mr. Chair. It does. I think we joke a lot in the legislature about making task forces and working groups and blue ribbon commissions, right? But we do it because it gets more people than us involved and people who have experience and lived it, and I think it's important. And so I think when a bill is coming forward to attempt to address a problem, and we made a task force to address that problem, and then there was a report from the task force on their recommendations that were unanimous to address the problem, and then the bill comes forward and it's not those recommendations, that's where I struggle.
Yeah.
It's not that I'm even disagreeing with anything that folks are saying up there. This is a really complex problem, and ultimately what we're all talking about is capacity. And so I guess that's just kind of where I've been like furrowing my brow. I'm gonna need Botox after this of just like reading all of this stuff. And that's what I keep coming back to is if we made a task force for recommendations and they were unanimous and a lot of folks who are sitting up here who were on that task force and agreed that that was a thing, then I'm just struggling with how we should move a bill that doesn't have that stuff from the people who said we have a report on the things you should do. I'll leave it there.
Senator Kevin.
Thank you, Mr. Chair. I understand that sentiment. I think it's important to look at this task force came together and there were a series of compromises that were reached so that people could agree. And that wasn't the sum total of all the positions that everybody had. I think the bill that we looked at last year came from a certain perspective that the counties felt like we have not been able to get some of our principal positions in now that the initial draft was kind of created. So we wanted to get that out there so you could see the importance of capacity and the 48-hour rule. There's not one or the other. But I think when you look at the kind of link, when you talk about was there agreement on 48 hours, the agreement was, we could extend this this 2-year sunset. We could send the 2-year sunset if there is the capacity. If there isn't the capacity, then we want the 48-hour rule back. I mean, that was the tension there. And that's why you see in the report itself a direct link between capacity, if-then. It's an if-then kind of relationship that we were clear about in there.
So before you go to the next thing, maybe Terrell Clark, if you want to come up, maybe Carrie or Dan, can you make room? I mean, I can add another. We need a bigger table up there, I think, for these conversations. It's like, Senator Maye Quade.
Thank you, Mr. Chair. I mean, I have more questions that are related to that bill, but not this specific piece, so we can let testifiers answer.
Thank you. And Senator, I got a text from, Abeler quoted Jim Stewart. We've quoted Jim Stewart a couple times in here. Do you remember when he talked about driving into and then on the right would be the people dressed like jailers, and they would, and then on the left, well, whatever, right and left. I'm not going to make a Republican-Democrat joke, Glenn. But on the left would be people that are in polo shirts, and they are mental health. These are experts. It was just this ability to separate some things in there. And it's like, I know you have a bill, and I don't know if it's today or maybe next week on this same topic, which is the task force itself and some of the recommendations on 48-hour. And so maybe ideas about this bill, that bill, and then what Ron Latz has got going, Senator. I mean, this is, and again, we're out on the steps 2 years ago at the front of the Capitol, and Kevin Magnuson and Brad Johnson show up, and we had. Do you remember that night?
I do.
So Senator Abeler.
Well, and just to be really short here, this is a really good discussion. I think we're not going to solve it today, Mr. Chair, but in terms of is this going to be a worthwhile task force? I think so. Senator Hoffman, before you convened that little meeting, the entities had never talked together. The commissioner didn't know our county attorney and all of that. At least now you've got a song sheet that you're all singing off of. There's no money, by the way. Sorry about the aspirational nature of this bill. But so at least there's some agreement with the other report and the collage and these together, but where we want to go. Yeah, there you go. And so there's at least an agreement. If we had money, we would do at least something out of the book that's being written and with you and Ms. Abderholden and the others. So, Mr. Chair, the thing before us, which is not before us just yet, but by April 11th, we need to kick out something from this committee that has no money. And I think the question is going to be, do we continue the 2-year thing that the department offers? Do we go back to 48-hour rule and have it not really work anyway? So that's my comment.
Which then, into that, Senator, it gets to what Senator Rasmusson said. We said we haven't fixed the system, right? I mean, it's like what we convened to do, but we can do that. So, Senator Commissioner, welcome to the table. You had something, you looked like you wanted to say something, and then I think we should probably agree that everybody's going to continue this conversation, and do you want to go to the next stop, right? I think I see Representative Congressman, Attorney General Ellison shaking his head. So, Senator Commissioner. Thank you.
Thank you, Mr. Chair and members. Terrell Clark, Stearns County Commissioner at this particular point in time. Thank you again for having us here, and I think part of this would be back to the question Senator Maye Quade had. Our task force report on page 24, recommendation number 2, extending the sunset provision for 2 years, during which time the legislature must develop DCT and community capacity. The review members agree that the sunset provision, ... should be extended for a period of 2 years, which must be conditioned on funding to increase capacity at DCT and in the community. That's a key part of this. That's how we got to yes at the end. There are many important pieces, and Senator Abeler, I do appreciate how long you've been working, how long you, Mr. Chair, how long several of you have been working on these issues. We need to get moving forward, and to have that happen, it really is about capacity. And so, yes, you have a lot of big issues to be dealing with, and we don't know what, if any, target you're going to get that could help with this. But we also know there could be capital that would start, right? Start making those steps, whether it's toward that 300-bed forensics facility that came before us at the end of the task force, whether that's a 20 or 10% increase, whether that's 50 more beds for AMRTC, there needs to be some actual capacity, because part of the reason why we all keep coming around some of these other pieces is there's been no new capacity really being able to be given. So that's the piece that I think helps clarify. This particular bill is an effort, again, to try to show what could be different if we could actually get some capacity moving forward.
Senator Radke.
Mr. Chair, thank you. And we're talking about capacity and all these different things. Do we have anything that tells us from DCT or others what it would cost to add these beds to Anoka?
I think that'd be,
To get, oh, go ahead.
No, Senator Rasmusson.
Thank you, Mr. Chair, and thank you, Senator Radke. I think that'd be a great question for direct care and treatment. I don't know.
Yep,
Mr.
Dr.
Short
Stevens,
Camper.
or do you need to get Dan up here to answer that? You're good, Dr. Stevens.
I know one number. If we need more than that, we'll get Dan back up here. 75 million. And
Say that number again?
75 million to build those 50 beds. It's shovel ready. The estimates has been done. The 20% across the board has not been done, and that would take longer time and more resources to plan.
And Senator Rasmussen, remind me in the audience, in the proposed budget that's in front of us, how much cuts are we expected to do out of this committee in order to enhance the $2.4 billion deficit in the outgoing years?
Thank you.
1.5, right?
Yes, thank you, Mr. Chair. Yeah, there's major cuts that are being made across the human services budget that are proposed, and I would say it's my understanding what the governor's latest position on for direct care and treatment is to basically ask for an operating increase that would maintain current capacity, and so I think what you're hearing from everyone, whether it's the Attorney General, whether it's the counties. I think everyone recognizes that there's a need for capacity, and the number that we just heard there, 75 million, that buys us an additional 50 beds at AMRTC, which would be a major capacity increase, right?
Yeah.
And it's shovel ready, and so I think these are things that we have to think about. And again, I'm not saying that the bill before the committee is perfect, but we know we have a problem. Status quo isn't working. And so I wanted to put these ideas in front of the committee as we're thinking about these important budget decisions going forward. But if we don't start working on this and chipping away at the capacity issues, we're going to fall further and further behind as a state, and it'll be harder for us to catch up.
As a follow-up, Senator Radke, and then we go to Senator Maye Quade, and then Senator Abeler. So, Senator Radke.
Okay, thank you, Mr. Chair. And as I hear these numbers being kicked around and talking about what the future budget may have to look like, but the fact is these expenses don't go away. We're going to pay them one way or the other. We need people to come to the table and have the hard discussions. We can do these things. There's stuff that we can put aside that's been appropriated over the last few years. It isn't needed. This should be a priority, and we can do it. We just got to have the will to do it. So thank you.
No, remind us why we exist, why we do what we do on this committee. I appreciate you saying that. Senator Maye Quade.
Thank you, Mr. Chair. This is a question. Is that a bonding bill for the 75 million? Could it be a bonding bill?
Doctor? Dan?
Dr. Stevens?
Dan?
Anybody? Dan, you want to, we got Commissioner, Senator Rasmusson, I'm sorry. I was looking.
Mr. Chair and Senator Maye Quade, it's my understanding that it is bondable. And so to do the construction costs, it's something that, could go to capital investment as well. Yeah, staffing would have to be funded through this committee.
Thank you, Mr. Chair. Senator Rasmussen, maybe we have a bill we could work on together.
I think these two are going to be doing something, Jim. Senator Abeler.
Well, thanks, and this will be my last comment for the day, because I know we have to keep moving, but Senator Hoffman, and as this committee is going to be the one to decide something. Yeah. And so just to recapitulate, the governor's plan was build nothing and increase the county share, and then continue this for 2 years, status quo. So that's the opening offer, and governors often get what they want. I'm not sure how it's going to go in this committee, Mr. Chair. And so not a lot of us are not eager to go to the county share thing. And we're just going to need some guidance to know what to do. And I know you all well, contingent upon money, we're going to go another year of this, 2 years of this thing. Good luck, there's no money. And so the question we really have to answer for now is, are we going to go with the 48-hour rule and try to jam that past? Or are we going to go with the 2-year extension? That's the practical place we're at, unfortunately. And then just hope that we can find some way to get some money. So that would be, and did you get that, Mr. Chair? I mean, we're not going to have any money, and so we're going to have to go with the 2-year extension and hope that money comes. That's kind of like what you wanted. Or just go with the 48-hour rule, which I kind of like, but.
In this committee, we're going to have that conversation. In the meantime, it'd be great if, the two senators that, chaired this committee last week would, get together and find
The Attorney General had a comment, Mr. Chair.
Attorney General, and then I think we'll probably end it. And Senator Rasmussen, we want to move this thing on to state and local government and keep that conversation going. I appreciate your work. I appreciate you all for being here. And Attorney General.
Well, Mr. Chair and Senator Abeler, the thought I had as I heard you share is that if we could do something, and I can't speak for the counties, they got very able counsel here to do that, but I think that, as was pointed out, their willingness to go along with an extension was contingent upon some progress. So if we can make some progress, we might not even be able to look, I'm not going to start bargaining against myself, but maybe we can't get to 50, but maybe we got to do something. And that, I think, and I don't want to speak for Kevin or Terrell, but that's the basis upon them saying we could agree with extension, but we can't agree with extension if we're not going to do anything. Is that right?
Mr. Chair.
Senator Abler's a
I thought I
follow.
was done. But anyway, so, there's a Miller building sitting there vacant. Can't that be good for something? You're talking like if you build it, it's not even going to work because there's no staff. You got 32 or 36 beds sitting up in Cambridge that are actually maybe could be unmothballed for buildings to do something. Maybe not like the intense thing, but a step down thing to be creative. And just, Mr. Chair, by the way, who decides if something is inadequate? We do, and by the way, there's no money. In the Depression, use it up, wear it out, make it do. The Fed's got no money. Did you notice? We don't have any money. The counties are about to have less money if any of these things go forward. So just encouraging, and Mr. Chair, I think we should move this without recommendation, just so we don't cause heartburn to.
I like that. So the motion
players.
is for move without recommendation. Do you want to add anything to that, or you want to wait till the next one, Commissioner, and then with Senator Wickland, then after you. So Senator Wickland, why don't you go ahead, and then we'll go to Commissioner Clark. Senator Wickland.
Thank you, Mr. Chair. I just wanted to add my comments that listening to all of the discussion that we've had, and then also reading the letters that we have from community mental health programs and others, I'm really uncomfortable with the lack of agreement that there is across this bill, and concerned about the provisions in it. And so I'm not able to support moving it forward. I think the discussion should be happening in this committee about what can we get to agreement on, and so I just wanted to make sure people were aware that I do have concerns about being able to come to some consensus about policy decisions, and the money. Yeah, I think we're not going to have money available to do very much of this, but I just think that that work should go on in this committee, and I'm hesitant to move it on to another committee. So, thank you.
I think Senator, no, I hear you on that, and it's absolutely, I think everybody, you get, it's the same thing. That's why Senator Abeler would have said move it without recommendation. I think it comes back to us, Madam Chair. I think this bill does come. Senator Rasmusson.
Thank you, Mr. Chair. And yeah, this bill ultimately would have to, go into your omnibus budget bill, right? Because there's appropriations and policy. And so I agree that the conversations on this should continue. Would ask that we move it on to state gov, and if in case they want to hear it and to also weigh in on these issues. But I think ultimately the bill would be a part of our conversations, and we're going to have to do something.
Yep.
Again, July 1, the 48-hour rule is back. And
I feel
so
that.
Bring competing proposals, bring ideas, bring amendments, bring suggestions. But I think, Mr. Chair, we're going to continue to be talking about this unless we start to work on the capacity issue. And whether you're hearing from the counties, the Attorney General, I think there's consensus that we have to do something about capacity and to continue to work towards that. Otherwise, we're going to have people sitting in jails in seclusion for 100 days waiting to get that medically appropriate bed.
Got it. Senator Abeler moves without recommendation to be referred to state and local government, Senate File 2628. All those in favor say aye. Aye. Opposed? No. The motion moves. Good luck in state and local government. Thank you, everybody, for your hard work on this. This is real stuff. Thank you. Next up, Senator Mann. Thank you for having patience with it. Senate File 1953, mental illness definition, modification provisions, medical assistance, transportation, reimbursement rates, modifications provisions, children at risk, bipolar disorder grant program, established provisions in children's first episode, a psychosis program appropriation. I want you to give me the DSM 3, 4, and 5 representation that you do as a doctor in the emergency room.
Thank you, Mr. Chair. That's
Senator Mann, thank you.
There's too many DSMs. Mr. Chair, members, Senate File 1953 is a bill that we worked on with the Mental Health Legislative Network. It does many wonderful things, including many of the things you mentioned, and also continuation of audio-only mental health care, expanding access to case management. However, the part that is relevant to this committee today is only Section 13 that increases the rate of non-emergency medical transportation costs. And that's it. With that, I'll turn to our testifiers.
So to that point, Ms. Abderholden, if you can keep it to Section 13, that would be wonderful. So Ms. Abderholden, please tell us who you are for the record.
Thank you, Mr. Chairman. Members, Sue Abderholden, Executive Director of NAMI, Minnesota. That section is related to protected transport, which is an alternative to transporting people who are experiencing a mental health crisis. It is basically an unmarked vehicle with the safety features in it so someone can't jump out and things like that. We only have about 2 vehicles in the state, and this could be actually a cost saver in terms of EMTs or sheriffs transporting people, especially in rural parts of Minnesota. So if we were to raise the rate just a little bit, we would actually get more vehicles on the road, and again, transport people with dignity.
Thank you. Members, this bill is marked to be recommended to pass and referred to Senator Wickland's committee. Is it going to stay over there, do you know, Senator Wickland, or is it coming back here?
No, I think, Mr. Chair, we already heard it, so we would keep it in our committee, I believe.
Re-referred. So you don't want it back? Do you want to keep it here, Liam? You want to give us some advice on that?
Mr. Chair,
Senator Abeler.
who gets to pay for Article 13, Section 13, if it gets bought? Is that us, or is that the good Senator Wickland's committee?
It's a great question. I'm surprised Senator Ecke didn't ask that question. Liam? Mr. Monahan?
Mr. Chair, members, the majority of the bill is in the jurisdiction of Health and Human Services. This particular section amends a program that is typically within the jurisdiction of this committee, but the incremental cost associated with this change could be paid for by whichever chair chooses to include it.
Senator Wickland.
Mr. Chair, I don't, maybe it could just be laid over here. I mean, we've heard it already, so I don't need to have it back in my committee.
Senator
already heard
Abeler,
it.
Senator Utke.
Smart move.
All right. So what do you want to do with this disposition? Look, we got everybody up here willing. Where do you want to go? You want to go to the floor?
Straight to the floor, Mr. Chair.
Can I go to the floor?
No, I cannot go.
She's doing this because she said it.
Mr. Chair, I
Senator.
know we're having fun. Is the only money in the bill that section?
Yeah. No?
There's more money?
There's more money.
Oh, okay. Never mind. I was going to take that out and send it to the floor.
And I think,
Thanks.
Senator Abel, that there's two systems out there, right? This one needs to be, am I getting this right, Mr. Monahan? This one needs to be by itself, but it needs this other piece, there's another budget proposal. There's two kind of going hand in hand. Am I misunderstanding this? It wouldn't be the first time I misunderstand something because,
Mr. Chair, I'm not sure I
We-
understand the question.
NEMT, we have NEMT proposal by the governor, and we have another couple of by themselves NEMT bills, and then we have this. So how are those interacting?
Well, they can't all be enacted. So between the two chairs and the various conference committees that hopefully will occur in May,
Yep.
all the parties would have to decide what is moving forward and getting enacted.
All right.
So if the governor's proposal were enacted, it's not clear exactly how this would interact with the governor's proposal.
So, thank you. That answers my question. I think Senate File 1953 should be laid over for possible inclusion into our omnibus bill. You guys all good with that? Yep, I think we're good. Senator Mann, thank you very much. Ms. Abderholden, good to see you. Thank you very much. We're going to lay this one over. Hey, I tried to get it to the floor with you, so. Senator Dibble, thank you so much. Senate File 1918, thank you and your team for your flexibility. Last week, we just, it is what it is, timelines. Chris Sundberg and Suzanne Scheller are here to talk with you about consent to electronic monitoring requirements modification. So Senate File 1918, and I think Aaron Huppert and Kyle Burnt are going to come up and give their testimony as well. And there's anybody else I had on this, I think we're good. Senator Dibble.
Thank you, Mr. Chair and members, for the opportunity to present Senate File 1918. And thank you as well for being a co-author, Mr. Chair. And so the description you gave is just kind of the tip of the iceberg. There are 9 elements to 1918. We do have an A1 amendment, which is the product of some conversation that happened with the Department of Health, and some tweaks and adjustments that are responsive to their technical advice. Do we want to take that amendment now?
Senator Maye Quade.
Mr. Chair, I move the A1 amendment.
Senator Maye Quade moves the A1 amendment. All those in favor say aye.
Aye.
Opposed, same sign. Senator Dibble.
Oh, and I'll just qualify. Since that time, they had some slight comment on the amendment, so that might need some tweaks going forward if we have that opportunity. Oh, here it is. Yeah, so I'll let them speak to that, perhaps.
Ms. Scheller, welcome to the Human Services. Thank you for your flexibility last week, too. I appreciate it. Nice seeing you again.
You as well. Thank you.
So I could present in just very high level, if you don't mind, what the subjects are.
I thought you were looking at
Yeah,
Ms. Scheller
I was
to
just
do her
making sure
thing.
she was aware of
Oh,
the
God, I'm
critiques
sorry.
of the amendment. I'll just go very, very fast. Ms. Scheller
Go ahead,
can,
Senator.
Then give the details. The first issue that we're dealing with is those instances when a resident lacks the capacity and a resident's representative is in the position to consent to electronic monitoring on their behalf, and private medical data is conveyed in that circumstance. And so we're trying to provide for an attestation mechanism so that that information is kept more private. The second issue is to strengthen retaliation provisions and provide for training in retaliation when necessary, and allowing some information to come forward in support of a civil claim. The third item that we deal with has to do with those who are represented on the Home Care and Assisted Living Advisory Council, as well as clarity on how fines are used that entity advises on. The fourth is having to do with what decisions people can make in the circumstance of being in hospice, particularly with respect to leaving hospice in order to access medical care. The fifth is the definition of a registered nurse in an assisted living facility, a nurse versus an LPN. The sixth is, I'm just up around, is when fines are collected and how that money is allocated in the assisted living setting and context, similar to what we do in skilled nursing. Let's see. Seventh is clarifying that folks are not required to sign an arbitration agreement as a condition for admission. The eighth has to do with ensuring that it's RNs, not facilities per se, that assess issues relating to medications. And the ninth actually was dealt with in Senator Wickland's committee, and that has to do with healthcare agents and those circumstances in which they are empowered to deny visits on the part of family members and others, and making sure that those thresholds are similar to the same kinds of thresholds we require for guardians to justify those kinds of withholding of visitation. So that is a very high-level overview, and now I can refer to Ms. Scheller.
Awesome, thank you. Ms. Scheller, welcome.
Thank you. Thank you, Chair Hoffman and members of the committee. My name is Suzanne Scheller, and I'm the legal advisor for Elder Voice Advocates, who works to promote quality long-term care for vulnerable adults. And Senator Dibble went through a variety of provisions in this particular bill. They're coming out of calls and many stories, not just one, that are coming to Elder Voice Advocates with concerns in that long-term care community. And so 1918 has several provisions in multiple areas of the law. I did want to highlight a few. One, notably, that in section 11, where there is an important change for arbitration provisions in assisted living facilities. In skilled nursing facilities, arbitration provisions are, as mandatory for a condition for admission, are already prohibited, and so we're looking to have a similar change in the assisted living environment. We are hearing several stories that prospective residents are asked to sign arbitration agreements as a mandatory condition of their admission. And we believe this violates the Arbitration Act, as well as what we know of the skilled nursing facility environment as well. Another one, retaliation continues to be one of the main concerns of residents and their families, that if they speak out in support and advocacy for themselves, they will experience retaliation, whether that is a limitation of their support system, who cannot come in to help them, or other matters. We are seeking to strengthen that, the retaliation provisions. Another one I wanted to highlight is the Hospice Bill of Rights. This continues to be a significant concern and call where loved ones and residents are not aware of the hospice rules and regulations. And so we're trying to take a step forward to make sure they're informed that if they wish to seek some treatment, that they may do so if they could either go off hospice to do so, or perhaps the treatment they're seeking is not part of the diagnosing condition for hospice, which would allow some curative treatment. We're also hearing reports of not having necessary pain medications on hand, and we have had family members dying in excruciating pain without having the pain medications that they would have expected once going on hospice. So we're concerned about how that the lack of information for loved ones when they're going into the long-term care setting, or they're in the long-term care setting in particular. The other one I will just highlight is the definition of a registered nurse. We defined LPN in the assisted living license definitions, pointing back to the Nurse Practice Act. We're simply suggesting that it's a good idea to point back to the Nurse Practice Act for a definition of registered nurse in our assisted living definitions, and the term registered nurse is used several times in the statute. So again, these are some high-level points of parts of the bill, and we wanted to get those before you to explain why we are here today with Senate File 1918. I appreciate your support.
Thank you, Ms. Scheller. Ms. Sundberg.
Thank you. I'm Chris Sundberg, and I'm Executive Director of Elder Voice Advocates. We believe the bill today is reasonable and necessary to prioritize resident well-being and impose modest requirements on the long-term care industry. The need is dire. We need these efforts here for several reasons. Our state ranks 16th worst in the nation for deficiencies found during annual nursing home inspections. From January 1, 2022 through September 2024, Minnesota nursing homes face 613 separate civil monetary penalties, totaling $9.2 million. The November 2024 report from the Centers for Medicare and Medicaid Services paints an even bleaker picture. 56 Minnesota nursing homes received the lowest possible one-star rating, citing severe safety concerns, understaffing, and substandard care. One facility alone racked up 158 deficiencies, $437,000 in federal penalties, and 98 investigation. Yet it continues to operate despite its long record of harm. The situation in assisted living facilities is equally alarming. While we lack the comprehensive data comparable to nursing homes, we do know that 26 deaths in 23 and 2024 were directly attributed to abuse or neglect by providers. A cohort study further found that assisted living residents had twice the odds of death compared to non-residents. Even in cases of severe neglect leading to death, the maximum fine for assisted living violations is just $5,000 per infraction. That's a mere slap on the wrist. We think this bill makes reasonable changes, strengthens protections, improves training, ensures fair stakeholder input, increases accountability, and it puts the elders' rights on equal footing with the providers. Thank you.
Thank you, Ms. Sundberg. Members, any questions for our testifiers so far? Senator Ruckey? Yes, Senator, we do. We have the long-term care, Aaron Huppert and Kyle Burnt are going to come too, but I thought as long as, because we're going to have to make room. Any questions for these guys? You want to wait till after Kyle?
I'll wait
and
till
Aaron?
they're all done.
Oh, good. That sounds good. Members, we're good? Kyle, Aaron, you want to come on up? And might want to get another chair, or you're good? Thank you. Thank you, Ms. Scheller. Thank you, Ms. Sundberg. Stick around. Who's going to go first?
I will, Mr. Chair.
Mr. Kyle Burnt. For the record, welcome.
Thank you, Mr. Chair and members of the committee. My name is Kyle Burnt. I'm here today on behalf of the Long-Term Care Imperative to testify in opposition to Senate File 1918. The proposal is a culmination of various policy changes to assisted living, nursing facilities. In Section 1, we are concerned that the provision would provide a pathway for a resident representative to attest to a need for electronic monitoring without having to provide documentation from a medical professional. This language gives family members an ability to circumvent clinical expertise and removes autonomy and agency from the resident. Seniors should retain the ability to determine if they desire monitoring in their own home or not, even if the family would choose differently. In the proposal, in sections 2, 3, and 14, provides a second penalty for retaliation. Subdivision 5 of the current statute already provides the Minnesota Department of Health the ability to determine retaliation and provide specific penalties. We believe these new penalties are redundant. And while well-intentioned, the proposed training on retaliation imposes another requirement that shifts caregivers and facility staff away from direct resident care and into an online portal or off-site training away from the facility. This requirement presents a financial burden to our members and is largely redundant, as similar training is already included in other professional development programs. At this time, I'd like to turn it over to Erin Hupert to finish our testimony.
Thank you. Ms. Hupert.
Good afternoon, Mr. Chair, members of the committee. For the record, my name is Erin Hupert, and I am also here on behalf of the imperative to testify in opposition to Senate File 1918. So to pick things up, we do share concerns about whether the Home Care and Assisted Living Advisory Council, the HCALP, is empowered to successfully carry out its responsibilities. However, we do not support expanding it at this time. They're really just getting their feet under them and getting up and running. We had an opportunity to review the A1 amendment this afternoon, so would like to have additional conversation with the bill sponsor and the supporters of the amendment and the underlying bill about what they are hoping to achieve with those changes. We do have concerns about Section 9, which modifies the definition of a registered nurse, as that would unintentionally exclude advanced practice registered nurses from providing care in an assisted living facility. APRNs are also licensed credentialed nurses who play a critical role in resident care, and we would hate to remove them from the ability to do their job. Two other things to note. The proposed change related to the delegation of medication requires further examination. While we do consider the ability granted in 144G.71 subdivision 3, the amendments to subdivision 5 are unnecessarily restrictive and may create inconsistencies in care delivery. And then my last note, we do have concerns and are opposed to the inclusion of Section 15 in the bill. This was discussed somewhat in the Healthcare and Human Services Committee, but we believe additional scrutiny and refinement is necessary. For example, including qualifying terms like significant to describe the amount of harm needed is counterproductive to the standard required by numerous professional licenses, as well as the Vulnerable Adults Act. So overall, this bill proposes numerous changes to long-term care statutes with some pretty broad implications and questions. We do look forward to additional conversations with Senator Dibble and others if this moves forward. Thank you.
Senator Abeler.
Mr. Chair, is this bill staying here or is it going somewhere?
This one is going to get to go in front of Judiciary and Public Safety Committee.
All right. And I think we should send this off without recommendation, although I like some of the ideas in there, particularly if one of the imperative people could just be aware of my concern, the thing about the Section 15 or something about the visits. If I get a single complaint from multiple people, probably a dozen at least over time, it's been from some facility not allowing this person to go visit them. And in the testimony of the person who wants to visit, this is the caring daughter. The other daughter is a horrible person, and they're the guardian, and then who never goes, and she wants to go, or the son wants to go, and there's no resolution. And of course, nobody can tell me anything, and if you knew what we knew, you wouldn't let them in either. And that's the problem. And I don't think they're all horrible people. And that one family in particular, Senator Hoffman, guardian angels, that fellow, I mean, and some of these loving relatives, they get so upset they become that person, and now they qualify to be, unpleasant to have around, but they were driven to that, I think. Anyway, so that if you could work on that in particular, and I'm sure nobody meant to exclude APRNs, so that's probably an easy one. Maybe just keep working, and we'll try to thread the needle on this. So, thank you, Mr. Chair.
And the RN, Senator Maye Quade, and then Senator Gruenhagen. The RN, what about the RN conversation too? The RN, LPN, that seems to always filter its way up, and I'm glad you brought the APRN. So Senator Maye Quade.
Thank you, Mr. Chair, and thank you, Senator Dibble, for bringing the bill. I really like a lot of it, and I think I had, my one piece of feedback, I think section 15, if I'm guessing, is, has to do with a place not wanting someone to come visit because it upsets them because they might not remember who they are, or they're older than they think they are, and that's different than like coming and harming somebody on purpose. And so I think there may be some working language there, but I think the intent of it is good, and I think it should stay in. And maybe financial harm doesn't have to be significant, I don't know. And then to the section 1 on the resident representative attests that the resident's medical professional determined. I'm assuming that it's not just a verbal attestation, it's probably a more thorough attestation, but I'm just reacting to Mr. Bernst's comments.
Ms. Scheller.
Thank you, Chair Hoffman, Senator Maye Quade. This has been some longstanding. It has to do particularly, I don't think there's any disagreement that someone needs to have a threshold finding of incapacity in order for an agent to make that decision. But it's a matter of the requirement of what the individual who is attempting to place the camera needs to do to get to that level. For one, we have been very concerned that this documentation, this letter by a physician, the request for the placement of electronic monitoring goes to the ombudsman. And so the idea that a medical record is needing to be accompanied with this application to place electronic monitoring in the resident's room is a concern. And the interpretation of MDH as to this language is requiring that very same thing. And so we simply have been trying to get the statute to be what we believe was originally intended, was simply that the person, there's an attestation that the person lacks capacity. There's an understanding generally from most people involved that a person does have a lack of capacity. So it wasn't primarily supposed to be about how do you support their lack of capacity, but rather that they do lack capacity. And so that's where this language is coming from.
Thank you, Ms. Scheller. Senator?
Oh, thank you, Mr. Chair. I appreciate that explanation. And like I said, I really think this is a good bill. I'm sure there will be changes along the way to address some of the specific concerns. The last thing I'm just going to say is I don't think anything has made me more sad than seeing, including language on ensuring appropriate pain medications are immediately available to a patient. You know, none of us probably in this room are currently like actively dying, and when you do, it is painful. And to not have pain medication in that process immediately available is torture. So we treat animals better than we treat seniors sometimes. And so I just thank you for bringing this, and that's really sad to see in that bill.
Respond to that, or you guys?
No, just Chair Hoffman, Senator Maye Quade, thank you for that recognition. It's critical. That's why they're going on to hospice, for that comfort. So
Absolutely. Senator Utke, and then I think there's a motion on it. Yeah, it's passed without recommendation and re-referred to Judiciary and Public Safety Committee. You guys want to debate that? Pass with or without, it doesn't matter. The fact is it passes. So, you know, Senator Utke.
Thank you, Mr. Chair. And unfortunately, I look at this a little differently than some others have commented. It kind of seems to be an assault on assisted livings that are working their tail off to serve the people they serve. But a couple questions, and this has come up already, the advanced practice registered nurses, the LPNs are left out of this. Are we gonna, as it makes a move, is that something that you will look at bringing back in? Because I think that, I mean, why would we take out some of those people that we need to make this work?
Yeah, I heard Senator Abeler bring that piece up, you know, and I think there was some head shaking about, this conversation's still happening. So is that true, Ms. Scheller?
yes, Chair Hoffman, Senator Utke, yes, there is conversation still happening. I do think at the very base level, this is simply a definition of a registered nurse, and we're certainly willing to hear the comments of how this may impact APRN. That is not the intention nor the thought process of insertion. It's simply a definition pointing to the Nurse Practice Act of what a registered nurse is.
Oh, I got that.
And so we use registered nurse throughout 144G, and it's simply defining what that is.
Senator Utke.
Thank you, Mr. Chair, and I appreciate that, but the one thing that always gets me, the more finely we define things in statute, the more we leave out. And that's why sometimes defining it like this, we're going to eliminate those other, professionals that would fit into this. So as you go forward, I would just hope that we make sure that we're inclusive rather than eliminating some that can work in these facilities and do what we need.
That's a good
Another
point,
question.
especially when we look at this bucket, there's 53,000 job openings. These are really, we want the consistency and we want to make sure people are doing what, we also need to have people in there. And is that an unintended consequence based on, like Ms. Scheller said, no, that wasn't the intent. The intent is just to define it. So that's something to really cogitorum on for a while. So Senator Upke.
Yep, thank you, Mr. Chair. Can the resident choose their own healthcare agent?
Ms.
Yes.
Scheller. Ms.
Chair
Scheller.
Hoffman, Senator Upke, that is true, yes. Any person, any of you all, myself, anyone would be able to draft a healthcare directive and choose who their agent would be in that healthcare directive. And certainly, that is part of our bedrock of those documents. I think what we see happening is that there is perhaps a going beyond or potentially not representing the interests of the principal, the one who signed the document, as to who they wish to not see or see. And so we have several calls related to individuals who have kept out a child when the resident themselves, the principal themselves, is saying, I want to see them. But yet the healthcare agent they've appointed, who they didn't think would ever prevent their son or daughter from allowing them to see their other son or daughter, is now operating in that capacity, and perhaps there's some diminished capacity. So yes, I'm going a little bit beyond maybe your question, Senator Upke, but yes, they can appoint their own agent. Sometimes the agent isn't acting in their best interest, and that's what we're concerned about.
Okay. Mr. Chair, that was part of what I was looking at, because if the resident can replace their healthcare agent at any time, it eliminates the need for a lot of this bill. It's kind of contradictory that they can just move this around. But anyhow, the last piece, are we emboldening the ability of the residents' representative to circumvent a doctor's note for this electronic monitoring?
Ms. Scheller.
Chair Hoffman, Senator Upke, no, we do not believe that is the case with this. Again, the idea is there needs to be a finding of incapacity, and so we are not circumventing that. There would typically be a diagnosis listed in the medical record. The long-term care facility at which a person resides would have that information. Perhaps they're in memory care for that very reason, because there has been some determination of diminished capacity. And so it wouldn't be circumventing a doctor's opinion in our estimation.
Senator Upke.
Thank you, Mr. Chair. That's all I've got, but the fact is we've got questions that I think need further clarification as this moves forward, because I think there are, I guess I'll leave it at, there's a lot of questions yet remaining to be answered.
My assumption is that you got a couple of stops after here, Senator Dibble. Is it just going to judiciary and then coming back here? Or is it going to judiciary and someplace else, do you know?
Mr. Chair, I think the only other committee I've heard that I need to go to is judiciary, and then back here.
Back here. So we got, you'll be able to ask these. I love this conversation. I mean, this really gets into the matter that you've been working on. Thank you, too, for working on this. This is something that, as long as I've known you, Ms. Scheller, this has been a passion of yours, and it gets to the why, what we're doing. Glenn, I think for the interest of time, if you want to just quickly say what you got to say, that'd be great. So thank you. Senator?
Yeah, what I would say, I don't want anybody not to get the pain medication they need, obviously, okay? And I see the intent of this bill. But is this bill, I mean, the way I read it on page 3, 3.21 to 3.23, and 3.26 to 3.29, we're going to increase costs of the nursing home and assisted living. And in my district, I already lost 2 nursing homes. I'm familiar with my assisted living, and all of them are right up to here with regulations and costs. So if we can address some of these things without driving up the cost for our nursing homes and our assisted living, I would be greatly supportive of that, because, again, I got a mother-in-law, 99, she's in assisted living, and I've got customers through my insurance agency or in nursing homes, and I know some of the staff, and they're right here, okay? And then the governor budget comes along, and he wants to cut millions of dollars out of the nursing home system all across the state. I don't know what can happen. So to the degree that you can figure out how to address some of these things, and Senator Utke had a recommendation, that without driving up the cost, and because we can't take any more cost out there, and pretty soon nobody's going to have cover or treatment. If you want to make a quick comment, that's my thought.
Well, welcome to Human Services, Senator Gruenhagen. Right? It's like we've been having, yeah. So you're catching on pretty quick. I love that. This is good. So Senator Dibble, I think there was a motion from Senator Abeler. I mean, if you want to respond, Ms. Scheller, to what Senator Gruenhagen's saying, if you want to, feel free.
Chair Hoffman, Senator Gruenhagen, respectfully, I just want to make sure I'm being pointed to the proper section of the bill because the amendment had some of those line items, but I think you're talking about the training provision.
Yeah, the training.
Yeah.
Yeah.
Okay.
The training and then the retaliations.
Yeah.
Legal action or whatever.
Yes.
I mean, that's going to
Yeah.
drive up the cost. I don't see how it's not going to.
Sure.
Yeah, go ahead.
Chair
Yeah,
Hoffman, Senator
absolutely.
Gruenhagen, I appreciate the comments. I just wanted to make sure of what you're referring to. And, yep, I have it. Thank you. And so we continue to have those conversations and appreciate the feedback.
Senator Abel, final thought.
Final
We're gonna-
thought,
let's
and then
move
I'll
this.
make my motion.
Can you make your
I
motion?
just want to encourage Senator Dibble and Scheller and other people promoting this and the imperative. If we can find, this is like a garage door sized bill, probably a 2-year project. Maybe there's a little side door. We can try to find some areas there's a lot of agreement on. That could happen this year. If it stays too big, I think you're going to wind up with nothing. And so I'd like to see some of these address the visitation and whatever other things that you can find a consensus on. I wish you the best on that.
Thank you, Senator. I love just continue this conversation you've continued on. I thank you for doing that, Senator Dibble. Any final words before we move you out to Judiciary and Public Safety?
Thank you, Mr. Chair, for the opportunity to present the bill, the excellent discussion, the observations, techniques. As always, I am very open door, very collaborative, and we take feedback and input and make adjustments along the way. And so I appreciate everyone who's at the table in good faith to respond to the needs of our seniors in these long-term care settings. Thank you, Mr. Chair.
Wonderful. Thank you, Senator Dibble. And I was going to make an amendment to put a bike path in there too for you, but that's just I'm glad you're smiling. Thank you again, Susie and Scott. Your work on this is absolutely, it goes for years. And this committee appreciates you guys really, the work that you're doing, the hard conversations that are happening. So Senator Abeler motion moved that Senate File 1918 pass without recommendation and referred to Judiciary and Public Safety Committee. Is that the motion that Senator Abeler had? So be it. All those in favor say aye. Aye. Opposed, same sign. You're on your way. Thank you.
Thank you, Mr. Chair, members.
See you soon. Thank you. We're going, Senator Fateh. You know what? Just for that, I'm going to table every one of Fateh's bills here. So, as amended. I'm sorry. Thank you. Senator Fateh, you got 3 bills. Senate File 2796, Waiver Case Management, Labor Market Analysis Requirement Provisions, Waiver Case Management Rate Increases Provisions. You got Jess Winstrom and Denise Dyer here. Denise Dyer is actually on the Zoomerang. And then you got Senate File 2596 coming up after that. So these 3 in a row, you're good to go. Senator Fateh, in 30 seconds or less.
Sounds good. Thank you, Mr. Chair, members of the committee. I'm proud to be the lead author of this bill to update and stabilize reimbursement rates for waiver case management services across Minnesota. Waiver case managers are the backbone of our health and human services system. They help people with complex needs navigate supports and services to live safely, independently, and with dignity in their communities. Yet for too long, the rates we pay for this critical work have failed to reflect the true cost of providing it. This bill proposes a flat rate increase for this vital service based on the cost of living increase over the past 10 years, which was the last time the rates were updated. It also proposes a study to establish a sustainable rate structure that ensures rates reflect the market. It addresses long-standing inconsistencies and underfunding that put both clients and the workforce at risk. And you'll now hear from two providers who can speak directly to the impacts of these outdated rates and the difference this bill would make for the people they serve. Thank you, Mr. Chair.
Thank you, Senator Fateh. Jess Wenstrom, Program Manager, Thomas Allen Inc. Welcome to the committee.
Thank you so much, Chair Hoffman and members of the Human Services Committee. Thank you for the opportunity to testify. My name is Jess Wenstrom. I live in South Minneapolis, and I'm a supervisor of case managers at Thomas Allen. I'm here to speak in support of Senate File 2796 to raise reimbursement rates for waiver case management. Waiver case management rates have not increased since 2015, and it's created a crisis-level workforce shortage directly impacting Minnesotans with disabilities. As a supervisor, I see daily how this staffing crisis harms the people we serve. Case management is a highly skilled role that typically takes about 7 months to learn. Unfortunately, the average case manager only stays about that long. I've seen so many case managers burn out before they ever feel confident in their role. Let me share 2 stories. The first client had 5 case managers in 18 months. Last October, while his case manager was in the process of switching from a DD to a CADI waiver, the position turned over. This man's waiver closed. His caregiver lost his income. Jared and his brother lost their housing, and they're now unhoused, living in a van. His medical assistance also lapsed, not because of an eligibility issue, but because the renewal paperwork did not reach him. Only now is his 5th case manager working to get his waiver reopened and help him find stable housing. All of this was preventable with consistent case management. In contrast, another client has had the same case manager for the last 3 years. When I first started supervising her case, she was in the hospital experiencing a mental health crisis. Her case manager helped her move into a supportive group home, and she gained stability. After a major medical event 9 months ago, that same case manager ensured her reassessment, reopened her DD waiver, and coordinated home modifications. She now lives in the community with the support she needs. She has no contact with her family, and without consistent case management, she would likely still be in crisis, or worse. Case managers are essential to keeping people out of crisis, ensuring cost-effective services, and protecting against waste and fraud. They help people remain in the community rather than in hospitals, crisis housing, or correctional facilities, outcomes that are far more costly for everybody. We are asking for a rate increase to catch up with inflation since 2015, and a rate study to ensure long-term sustainability. These steps are critical to reduce workforce shortages and ensure Minnesotans with disabilities receive the support they deserve. Thank you for your time and consideration. I'm happy to answer any questions you may have.
Thank you so much, Ms. Wenstrom. Questions, members? No? Let's go to on Zoom. Ms. Dyer, are you there?
I am here. Can you hear me okay?
I can hear you and see you all the way from Clay County.
Moorhead, Minnesota. Good afternoon, Chair Hoffman and members of the committee. My name is Denise Dyer, and I've been a county agency social worker and waiver case manager at Clay County Social Services for 16 years. I serve people with physical, developmental, chemical health, and mental health disabilities. I work directly with individuals, their families, and providers to ensure people have access to the services they need to thrive. I also oversee all waiver cases in Clay County that are contracted to outside agencies, providing support, consultation, and quality assurance to ensure the highest quality service delivery. There's a growing shortage of waiver case managers in Minnesota. The turnover that agencies face harms the people we serve in unnecessary and heartbreaking ways. One person on my caseload has had 3 different case managers in the last 6 months. So retelling your life story, your biggest challenge, your needs, your traumas, it's exhausting, it's frustrating, and it's often re-traumatizing. Now imagine having to do that over and over again because your case manager keeps changing. Case managers provide a safety net for the most vulnerable people in our communities. We support individuals, but we also oversee the services they receive, making sure the providers and their staff are meeting the person's needs, respecting their rights, and treating them with dignity. I serve a young man who lives in a community residential setting. In his previous home, I had serious concerns about the staff following his life-sustaining overnight medical protocol. I went to his home during the overnight after being told by the provider that the staff was following the protocol, and I found the staff sleeping. They were not following the protocol. People we serve come to case managers for help with everything, whether it's legal issues, trauma, advocacy, substance use, mental illness, benefits, housing, and more. Sometimes they want us to be their friend or family because they don't have any. The case manager is the key to helping people reach their goals and to live with dignity and independence. Case managers need significant knowledge, experience, and well-developed skills to do this job well. We're policy experts, resource navigators, behavioral specialists, fraud preventers, and safety advocates. In one recent case, I uncovered $100,000 a year cost savings for one person served by correcting how the customized living services were authorized. But this work takes a toll. We see some of the worst things that can happen to people, and we carry that with us. Reimbursement for case management comes from medical assistance and covers not just wages, but admin costs and agency overhead. In 16 years, there has been 1% COLA increase in 2015. Some job ads for case managers offer as little as $21 an hour. Investing in the case management workforce will stabilize services, support people with disabilities in meaningful ways, and reduce pressure on other community resources. It will help agencies recruit, hire, and retain experienced, knowledgeable employees with the skills needed to do their critical work. Most importantly, it gives people with disabilities the dignity of living to their full potential in their communities. The proposed increase may add to the budget initially, but it will lead to extensive long-term savings in areas like jails, police, courts, emergency services, hospitals, and fraud prevention. Thank you so much for your time and consideration, and I appreciate the opportunity to share my perspective and stand for any questions you may have.
I have none. I just did one observation. Your CLIPS program that you have in Clay County is absolutely an amazing program that the rest of the state should see how you guys do that work. Just, I don't know if you're familiar with that. Are you?
Not so much, no.
Yeah, it's.
But I will pass that along.
Pass that along. No, seriously, I mean, Clay County is really good. Members, this bill, we're going to lay it over possible inclusion of the omnibus bill. Anybody has any comments or questions for our senator? Not? This one's laid over. Thank you, Senator Fateh.
Thank you.
Senate File 2596, positive support professionals and positive support analyst qualifications and modifications. You're going to introduce an A2 amendment. You have Rachel Friedman, Dr. Rachel Friedman from Senate Research Associate from the ICI, University of Minnesota. Woo, wow, that's like the University of Minnesota right here. How do you get in that? Is that in Minneapolis? Heather Wilford from Board Certified Behavior Analyst from Mansell's, and then Donna Cobb from Affinity Care, Minnesota. Anybody else you got that you want to add there, Mr. Fateh? Senator?
You can come join us too if you'd like.
I'd love to. So you want me to give the gavel over to, who do you want, Utke? The good, the bad, and the Utke on this one? So, Senator Fateh, to your bill, your A2, you want to bring that up right away?
Yes, I'll move the A2 amendment, Mr.
Those members, the A2 amendment puts it in the manner that he wants. All those in favor say aye. Aye. Opposed, same sign. Senator Fateh, to that. Now the bill is in how you want it. Talk to us.
Thank you so much, Mr. Chair, members of the committee. Thank you for the opportunity to present Senate File 2596, a bill designed to expand and improve access to positive support services, a critical yet underutilized resource in our disability services system. Positive support services, formerly known as behavioral support, are individualized, person-centered interventions that proactively address challenging behaviors for both adults and children. These services are grounded in evidence-based strategies and aim to enhance a person's quality of life by building positive behavior and functional skills. They are often delivered in homes, community settings, or licensed residential facilities, and they play a vital role in keeping individuals safely supported in the least restrictive environments possible. Unfortunately, current access to these services is severely limited due to outdated staff qualification requirements that do not reflect what research shows is effective. Only about 20 organizations in the entire state are currently offering positive support services, leaving significant gaps, especially in greater Minnesota and in communities that already face systemic barriers to care. Senate File 2596 addresses this workforce bottleneck by reintroducing a competency-based training pathway, restoring pre-2019 experience standards, and funding a statewide positive supports competency program. These changes are essential to building a qualified and diverse workforce and ensuring families can access the supports they need. Thank you, Mr. Chair. And with that, I'll pass it over to our first testifier, Ms. Donna Cobb.
Right here.
You're going to Donna Cobb, Intervention Services Director, Affinity Care, Minnesota. Welcome.
Thank you, Mr. Chair and members of the committee.
You might want to get closer to the microphone because, you know.
Can you hear me now?
Absolutely. Senator Utke? Thank you. Go ahead.
Thank you, Mr. Chair and members of the committee. My name is Donna Cobb, and I serve as the Independent Service Director with Affinity Care MN. I oversee the implementation of positive supports under 245D. Today, I'm testifying in strong support of Senate File 2596. Positive support, formerly known as behavioral supports, are individualized, person-centered services designed to proactively address challenging behaviors for adults and children. These services focus on developing, implementing, and monitoring a customized plan to enhance a person's quality of life through skill building and promoting positive behavior. This service is essential. We support individuals across various settings, whether they're living in their own homes, licensed residential facilities, or navigating homelessness. The goal is to reduce behaviors that interfere with stability and community integration using evidence-based strategies that are proactive and not punitive. Despite the importance of positive support, significant barriers prevent access. The U of M in 2022 statewide research report confirmed providers reported difficulty meeting current qualifications for positive support staff. Families across both metro and rural areas said they could not find anyone to provide their services, and in some communities, people don't even know these services exist. Individuals with complex needs are getting stuck in hospitals due to lack of trained community support professionals, and only 20 organizations statewide provide positive supports due to staffing challenges in regard to the rigid qualifications. SF 2596 proposes targeted, research-based solutions to address these issues. First, it removes the outdated and restrictive experience requirements for both the professionals and the analysts returning to pre-2019 standards. This current 2-year requirement is a bottleneck and not reflective of what research shows is necessary for success in the role. 2, it introduces the competency-based training pathway for positive support, aligning with best practices seen in other states like Virginia and Missouri, which competency models have expanded access and maintained quality. It also includes our appropriation to establish statewide positive support competency program. This investment would fund the development of free accessible training modules, tools for tracking, evaluating staff competencies, regional mentorship systems, and a community-led competency-based review team. The goal is to build a sustainable, universal training infrastructure that increases both the number and diversity of qualified positive support staff across Minnesota, particularly in underserved communities. These are not just administrative tweaks. These changes would make life-changing services more accessible and equitable, particularly in greater Minnesota and the underserved communities that have historically has less access to specialized behavioral supports. And we made progress. Last year, I testified in support of updating the qualifications for positive support staff, and I'm proud to say the change has partially adopted, reducing the required experience for analysts from 4 to 2. Additionally, the most CSM waiver amendment now allows positive support to be delivered in hospitals, which is a critical step toward addressing the acute care transition crisis in our state. This is a major win for individuals who need timely, specialized support during hospital stays to supported community integration. Positive supports are a critical part of Minnesota's response to mental health crisis and the ongoing workforce shortage in disability services. Let's ensure these supports are available for the people who need them, when and where they need them at. Thank you for your time and attention, and I'm happy to remain available for any questions.
Thank you so much. Your next testifier, please introduce yourself for the committee, and you may begin your testimony.
Thank you, Mr. Chair and members of the committee. My name is Dr. Rachel Freeman. I work at the Institute on Community Integration at the University of Minnesota as a senior researcher and director of a positive supports training and technical assistance project. My testimony today is informed by the community partners that are here today and others who support people with complex needs. And that is in residential, employment, family homes. I also collaborate with other states that are implementing similar types of strategies across the U.S. I've conducted a number of research studies, and my colleagues have as well, at the University of Minnesota, which confirms everything that Donna has been saying. And that is that children and adults with complex needs, for instance, who enter into an emergency room for a variety of reasons, find themselves unable to get home because the community services are just not available.
families in the metro and in rural areas are all saying the same thing, that there just aren't anybody, there's no services, they can't access this positive support service. And only 9% of licensed providers are actually utilizing the service. So you have a service that's not being used right now, and it's a chicken or egg question, which is you need to have the training systems in place in order for people to be able to access this type of support that will solve some of the challenges that we have in the state around the acute care crisis, where there are barriers to transition. So positive supports, as a background, is evidence-based practices that are person-centered, that meet the needs of all Minnesotans, and that are data-based, so they collect information that provides evidence that things are actually working for people and quality of life is getting better. National and international research clearly recommends that evidence-based interventions that we call these positive supports in Minnesota are really necessary to ensure positive services across community settings. And also that it's cheaper, right? It's cheaper to provide community services, but we must invest in these, and we have this service that we can move forward in the state of Minnesota. Being competency-based just means that there's evidence that exists, that what you're implementing is actually what's indicated as best practice within research. SF 2596 provides a community-developed strategy that's comprised of providers across the state. So they're working with us to develop this and address the barriers encountered in community and positive supports in a way that will leverage these resources. So as a small, modest, one-time investment in training materials, guidelines, and tools, we can increase the access and use of this effort, and also change the qualifications to make it a little bit easier, because you can use the training materials and then also then get access to the billing and reimbursement services. So what is being requested through this is minor changes to the qualifications, thereby creating a pathway that allows individuals with a bachelor's degree to demonstrate their competency. So instead of getting a higher education degree, the doctor or the other types of higher education, you can demonstrate your effectiveness in rural areas where maybe there aren't that many specialists, and we know that's a problem across the U.S. The competency-based program itself needs to have a plan to really move forward with this, and using easy competency-based tools to provide a clear list of what's needed, guidelines and stories from the folks that are implementing positive supports so they can mentor others within their local regional settings is another piece of the puzzle. Disseminating resources that are available across the state so that it's easier to get folks trained and prepared to use this service is important. And that becomes a part of this process of mentoring and helping support other organizations that may not be able to get to this point to use positive support services. Part of this is also meant to say, if we have a pathway where you can be approved to implement positive support services with a bachelor's degree, that there's a competency-based review team that can look at that information, and they're individuals from the community with expertise that can approve this. One of the issues is really leveraging the resources that are already available in the state for these efforts, and so that's one of the pieces of this puzzle. By increasing a one-time allocation of appropriation of funds, we'll be able to build on what we know is already happening within the state and the funds that are allocated, and providing those free resources becomes a piece of the puzzle. And as Donna mentioned, there's other states that are doing these kinds of efforts. They're implementing slightly different efforts because each of our states are very different. But the key is that positive support strategies requires a mentoring and coaching process in order to really make sure that people have the support they need to implement effectively. So Virginia and West Virginia, Maryland, Massachusetts, and Missouri are all states that have reached out to us in the state of Minnesota, but also are sharing their expertise as well. So I thank you for this time to share the information about this SF, let's see, what is the 2596, thank you. And if you have any questions, please ask me.
Thank you, Dr. Freeman. And to your final testifier, please introduce yourself for the record. You may begin your testimony.
Thank you, Senator, and thank you, committee. Good afternoon. Thank you for the opportunity to speak today. My name is Heather Wilford. I'm a board-certified behavior analyst. I currently serve as the organizational positive support strategist at Mainsville Services. We're a home and community-based service provider, and I'm here today to testify in support of the Senate File 2596. In my role, I provide direct interventions and support to individuals while also overseeing the expansion of these services within our organization. I work with a diverse range of people, including young children and their families, older adults in residential settings, and individuals facing crises in hospital settings, just like we've been talking about today. I've supported people dealing with grief-related aggression towards others, suicidal ideations, and severe self-injurious behaviors that has led to hospitalization. These are just a few examples of the situations where mental and behavioral health supports are essential and emphasize how critical positive support services are. Despite the growing demand for positive support services, as providers, we continue to face significant challenges in delivering these very services effectively. One major barrier is recruiting and training competent staff. The current standards for qualifying as positive support specialists, analysts, and professionals rely heavily on years of experience in college education. This focus creates difficulties for providers in finding individuals to fill these roles and ensuring that they have the necessary competencies to actually do the work effectively and not cause any further harm. Shifting to a competency-based model would allow for more flexible, fair, and accurate assessment of a professional's abilities. By prioritizing competency, we can build a more inclusive and effective workforce, provide meaningful training, and ensure that professionals meet high-quality standards, rather than simply fulfilling a set number of years in the field or number of hours towards learning specific focus. Additionally, transitioning to a competency-based approach will help address workforce shortages, improve retention, and provide professionals with clear pathways for career growth, leading to better outcomes for those we serve. This model will also provide a framework for effective training and establish a consistent standard for service delivery across the state. In conclusion, the people of our state deserve effective treatment from competent professionals, and the changes proposed in Senate File 2596 can help make that possible. Thank you again for your time and consideration, and I'm also here to answer any questions.
Thank you. Members, questions? Okay, Senator Fateh, any closing remarks?
Yeah, I just want to thank the testifiers for coming and sharing their stories and sharing the need for this legislation, and hope to get it laid over.
Thank you. That was my next question. All right, so Senate File 2596 as amended is laid over for possible inclusion in a future omnibus bill. Senator Fateh, Senate File 2741.
Thank you, Madam Chair and members of the committee, for the opportunity to present SF 2741, a bill that will address a critical delay in access to housing stabilization services, also known as HSS. HSS is a Medicaid-funded benefit that helps people with disabilities, mental illness, or other complex needs secure and maintain stable housing. It supports individuals through housing transition, sustaining tenancy, and overcoming barriers to stability. For many, especially single parents, survivors of domestic violence, and people exiting homelessness, HSS is a lifeline. However, under the current structure, all HSS authorizations must be processed centrally by DHS. This has created a significant application backlog, with families waiting up to 4 to 6 months for approval. Delays that are putting people at risk of eviction, extended homelessness, and service lapses. SF 2741 offers a targeted and efficient solution, allowing waiver case managers who are already responsible for developing and overseeing a person's support plan to authorize HSS for individuals on waivers. This will not only reduce administrative burden on DHS, but more importantly, it will allow services to begin where they are actually needed, not when they're actually needed, not months later. And with that, Madam Chair, I'll pass it off to our testifiers.
All right. Whichever testifier would like to go first, please introduce yourself for the record. You may begin your testimony.
Good afternoon, Chair and honorable members of the committee. My name is Twyla Martin. I'm the CEO of 360 Housing Stability. We are a culturally responsive housing stabilization provider, serving hundreds of Minnesotans, many of them parents who are navigating disability, housing instability, and often trauma, generational trauma. I'm here today in a strong support of subsection within SF 2741 that allows waiver case managers to authorize housing stabilization services directly. Right now, our system is failing the very people it's designed to serve. Under the current structure, waiver recipients must wait up to 60 days for DHS to approve service plans, despite already having an established support plan in place. but many case managers submit renewals just weeks before expiration. That timing gap leaves individuals without services for months at a time for the families we serve. These gaps aren't just inconvenience, they're devastating. I had to tell a mother who uses a wheelchair and raises 2 children that we have to pause services for her, not because she became ineligible, not because we weren't willing, but because the paperwork didn't move fast enough. The mother didn't stop needing support. Her children did not stop needing stability, but the system forced us to stop anyway. When approvals do arrive, they often come with just a few days of authorizations left. In one case, we received approval 1 day before it expired. That meant starting over with another 60 to 90-day delay. These are real families, real people trapped in a cycle of uncertainty simply because of preventable administrative delays. Housing stabilization providers like mine are left in a difficult position. If we provide services proactively, we risk not being reimbursed. If we wait for approval, the families suffer. It's not just discouraging, it's demoralizing. We are doing the work. We are stepping in when people are in crisis, but we are being punished for showing up too early. This proposed change offers a practical and meaningful solution, allowing waiver case managers who already are developing and monitoring the person-centered plan to authorize services continuity, reducing unnecessary delays and align service delivery with the service real-time needs. These case managers are the closest to the individual and best positioned to act with urgency and accuracy. Importantly, this subsection doesn't increase spending or create a new benefit. It simply streamlines access to a service that has already been approved. And for families we serve, particularly parents trying to hold their households together through their harsh realities of disability and poverty, timing can mean the difference between stability and crisis. You have the opportunity today to remove systematic barriers that unjustifiably affects families in crisis. To say that stability, safety, and dignity should never hinge on a paperwork backlog, this is not a request for more. It's a call for access, accountability, and timely support. Please support this subsection. Let's make housing stabilization work the way they were intended for the people who need them most. Thank you for your time, and I am happy to answer any questions.
Oh, sorry. Thank you, Ms. Leach. I was like, thank you. Ms. Murray, welcome to the committee.
Hello, Mr. Chair and members of the committee. My name is Ade, and I'm the Executive Director of Seeds Worth Sowing, a grassroots nonprofit based in Minnesota. We walk alongside low-income families, especially single mothers, who are navigating the compounding challenges of housing instability, disability, and trauma. Our mission is to create pathways to stability through culturally responsive, community-based support. Every day, we serve women who are doing everything they can to build safer, more stable lives for their children. Many are living with disabilities while also managing the weight of poverty, domestic violence recovery, and inconsistent access to care. These mothers are resourceful, resilient, and committed, but they need systems that work as hard as they do. That's why I'm here today in strong support of Senate File 2741. This bill would allow waiver case managers to directly authorize housing stabilization services, a critical step towards reducing harmful delays and ensuring that families receive timely support. Under the current process, even when someone is already on a waiver and eligible, we routinely see 4 to 6 month delays in getting approval for HSS. That delay is not just administrative, it's deeply consequential. We've seen mothers lose housing opportunities, face eviction, or return to unsafe living environments while they wait. By the time an organization is finally approved to step in, conditions have worsened and become more complex, something that could have been prevented. Waiver case managers are not only capable of authorizing these services, they're already doing it for most other aspects of a client's care plan. They understand the nuance, the urgency, and the goals. Granting them this authority would create a more responsive, person-centered system, one that reflects both compassion and common sense. When mothers are supported in finding and maintaining housing, it doesn't just transform their households, it uplifts entire communities. Children are more likely to stay in school, emergency systems are less burdened, and neighborhoods stabilize. SF 2741 is a simple strategic step toward
ensuring that the safety net we've promised actually catches people in time. Thank you for your time and your care in considering this bill. I strongly urge your support, and I'm happy to answer any questions.
Thank you. Senator Fateh, I thought on 1.19, the $3,000 moving expense, didn't we have something last year where we actually, am I thinking of the wrong bill, but I thought we had a moving expenses for folks clearly within the waiver case management program as well. And I thought, did we not get that 3,000? What did we do last year? Do you know, Ms. Leach?
Yes, Ms. Martin.
Did I say Ms. Leach?
Yeah, I got married.
Well, congratulations, Ms. Leach. You, Martin, yay.
Thank you.
And you didn't we're celebrating. Where's the cake, people? I mean, this is like.
So the moving expenses was granted April 1st of last year of $3,000, and it is being exercised and used, and it is being much help. However, the eligibility times are so short when it comes to CADI case managers, clients. We're unable to actually use them on time, and so this is the need for to push this bill.
Okay, thank you. And so, Senator, you had requested a fiscal note. Did anybody give any indication of what that potentially could look like?
I think it's
at
still
all?
in the process.
Do you know?
It's still in the process, so.
Still in the process? Okay. So you want to lay this one over too in the
Yes.
hopes that we get the information we need, Senator?
Yes, Mr. Chair, I appreciate it.
Awesome. Members, we're going to lay this one over for possible inclusion, Senate File 2741. Thank you, too, very much for being here. Good to see you. Good to see you. Thank you, Senator. And now we're going to go back to the front page, and it'd be Senator Maye Quade, Program for All-Inclusive Care for the Elderly Service Delivery System Implementation Provision. There's going to be an A1 amendment that you're going to have. Is that correct, Senator? And I think Wayne Olson, you used to be with Volunteers of America, and now you're with Presbyterian Homes. How are you? Good to see you. Welcome back. You got John Tao, he's on Zoomage, and then Eric, you're here too. Eric Nielsen, who is with Volunteers of America. Now, full disclosure, my brother-in-law happens to be your accountant. Is that correct?
He was in the past.
Okay, good. So there's no full disclosure, just in case somebody in the audience wants to, try to say I have a freaking full disclosure here. So, thank you, Senator Maye Quade. You have an A1 amendment.
I do, Mr. Chair.
All those in favor of the A1 amendment say aye.
Aye.
Opposed, same sign. Senator Maye Quade, now it's in the form that you like and desire. It's all yours.
Thank you, Mr. Chair. Before you, Senate File 2755, which would expand and protect the services delivered by the Program of All-Inclusive Care for the Elderly, or PACE. PACE is a comprehensive and integrated system of care for older adults who are eligible for nursing home care but wish to remain in their own home and communities of choice. PACE provides a full and comprehensive range of essential medical and social services, including primary care, specialist services, prescription drugs, physical and occupational therapies, and transportation. Additionally, PACE offers meals, social activities, and other engagement opportunities to keep older adults active in their communities. Aside from better health outcomes for Minnesota's aging population, PACE offers two other primary benefits. The first is cost savings. Studies have suggested that PACE can generate cost savings for both the state and federal governments compared to traditional fee-for-service Medicare and Medicaid programs by reducing hospitalizations and nursing home admissions. Additionally, PACE provides high-quality care at a lower cost compared to other Medicare Advantage plans, nursing homes, and waivers. And the second is there is a higher satisfaction with care. PACE provides person-centered care, which meets the needs and preferences of older adults. Studies have shown satisfaction among PACE participants and their families, specifically with the quality of care and communication with healthcare providers as compared to traditional Medicare Advantage plans. Potential cost savings and improved health outcomes for PACE participants establishes a promising model for providing individualized and high-quality care for Minnesota's growing aging population. The expansion of programs like PACE is driven by the desire to improve the quality of life for our seniors, while also reducing the burden of healthcare costs through improved care coordination and preventative services. And I urge your support for this bill, and I would welcome my testifiers.
Thank you. Wayne Olson, Director. How you doing?
Very good. Chair Hoffman and committee members, thank you for your time today. Again, my name is Wayne Olson. I work with Presbyterian Homes and Services. We are, as are other organizations in the senior care profession, excited about the opportunity for Minnesota to become a part of PACE and to bring PACE to the state. The program itself has a 50-year history in other states,
and has shown high levels of success, high impact for frail seniors who are nursing home eligible but wanting to live at home. We and others have been engaged with DHS in exploring what PACE would look like, how it could be stood up as a program in Minnesota. There has been conversation, issue identification, aspirations for programs, impact, and identifications of pathways to have PACE become a reality. We and others have appreciated being at the table in this formulative time for PACE in Minnesota. Two key foundational activities have been completed recently: the actuarial study, which will lead to a specific rate methodology, and the submission of RFIs by a number of interested parties to demonstrate continued interest and commitment. DHS is now working to make various decisions and provide the foundation for how a program could work in Minnesota, and we and others stand ready to provide feedback and context to have a successful program developed in Minnesota. PACE is a program that has flexibility to meet the needs of an increasingly diverse population in Minnesota, all trying to navigate the healthcare system with the goal to stay independent in their homes. It is this program which serves equally well in urban and rural settings and has similar impact. The program has capacity for an ultimate level of service coordination and access, using a full continuum of services in a consolidated centralized service center. PACE has proven success in combining the best in senior care, matching to the needs of the individual with the engagement of the family unit. And this care is provided at a payment rate which would be less than otherwise expected at the county level. This with a high level of satisfaction. Services are all-inclusive, meeting all the needs of the seniors. I would leave you with three numbers. While nursing home eligibility is required, 94% of all PACE participants continue to live in the place they call home. Families willing to recommend to others is 95%. And in order to support a variety of services and wrap around these opportunities for seniors to age gracefully, transportation is an important part. And the average participant receives 16 trips, transportation events per month. PACE is a wonderful program. It has 50 years of experience. It's a program our seniors in Minnesota deserve to have access to. It is a program that brings quality, efficiency, using less than half of the FTEs that staff would be needed for equivalent in a nursing home setting, and a very high level of satisfaction. I thank you for your time and your consideration.
Thank you, Mr. Olson. Do you want to go to John Tao next, or Eric? You want to go to John Tao on the Zoom, or you want to do Eric here? Mr. Tao?
Yes, I'm here. Mr. Chairman and honorable member, thank you for the opportunity. So excited to share my story. Recently, July 1st, 2024, we just opened both PACE in Fresno, and we are mainly targeting the Hmong populated California, especially in Fresno. And as you already know, at Twin City, you have over 86,000 Hmong populated Twin City. And assured that there are more than 15,000 seniors living in Twin City. I want to share my story in Fresno, the Board H Fresno Center. We opened in July, and a lot of senior elderly Hmong and Laotians, they gave into a program opening for 6 months, and we had enrolling more than 80 participants that compared to other PACE. At the same time, on July 1st, when we opened PACE, there are other programs also open too. Comparison for the Asian community, we have over 80 participants enrolled to the program. Compared to mainstream, they only have 20 participants enrolled to the program. So I encourage all the honorable members and yourself to support this bill. We have a lot of Hmong Laotian live in Twin City. They do need these programs. My patient shared the story that ever since she came to the program, have helped her and have bring her family together. She was at the nursing program, I recruited her from the nurse program into the PACE program. And ever since she stayed in the program since July to now, she's happy. She get all the quality care. She get all the access to mental health. She had every day she comes to the center, she have blood work, her sugar, her cholesterol check every day compared to primary care. Primary care takes about 1 to 3 month appointments. The PACE programs, they came to the program, they have every right to check every day on their blood sugar, their high blood pressure, and cholesterol. And she said that it helped her, and she becomes strong in everything. And now and then, she connect to her family. Now she stay at home now with her family, and she's so happy. One of the stories that I shared to you, that this program, it worked for the community, and I echo to all of you in Twin City, please support this bill and support this cause because it will help eventually help the Mount and Atlantic Ocean and Minnesota. And you may ask me any question if you want to, and I'll be here to answer your question as if you want. But thank you for the opportunity to share this story to you. The PACE program saved us a lot of money and also help a lot of seniors connect to their family, especially the Asian community. They like to connect with their family. They like to stay close to their family. They always been a tradition and always the culture that Mount and Leo should have in their entire life. And thank you for the opportunity.
Watch out, Mr. Tao. Thank you for your story. I appreciate that. Eric Nielsen.
Yes. Hello. Thank you, Chair. My name is Eric Nielsen. I'm the Regional Vice President of PACE Operations for Volunteers of American National Services. We have been operating PACE for over 16 years. We have 7 current programs throughout the country in 5 different states. PACE is currently offered in 33 states and the District of Columbia. PACE is serving over 82,000 participants across 184 PACE programs. The PACE industry has seen rapid growth over the last few years. This growth is brought on by more and more states recognizing the value of PACE and the value it brings as another healthcare option for their constituents. Over 90% of family caregivers in PACE would recommend PACE. Likewise, PACE participants rated their satisfaction as 4 out of 5. That, combined with the quality impacts of lower hospitalization rates, decreased rehospitalizations, reduced ER visits, and nursing home admissions. States are seeing the positive impacts PACE can have on their population. The states that have integrated PACE have a successfully good understanding of how and where the PACE program fits into their healthcare options. As a born and raised Minnesotan, I have seen firsthand the challenge of caring for a loved one who wanted to age in their home instead of a nursing home, and to try to fulfill that wish without our state offering a PACE program like PACE. The financial, mental, and emotional toll that takes on the person, and not only the person, but that person's loved ones, is difficult. PACE is a great alternative to nursing home care while allowing people to age in their home and community with dignity and access to the high-quality care they deserve. 33 states have fully embraced PACE as a cost-effective, high-quality, and high-satisfaction alternative to nursing home care and managed long-term care. This alternative in Minnesota is long overdue. Thank you for your time today, and I'm available to answer any questions you might have.
Thank you. You know, it seems that Senator Maye Quade, I looked down, and this conversation has been going on, and when it was like 33 other states do, but not Minnesota, it's like, you know, nothing to see here, Senator Abeler.
Well, Mr. Olson, can you just remind me, when did we start trying to get this going? It was you and
Yeah, it was
me.
about 4 years ago.
Only 4? Just seems like.
Yeah, it might be the 5th, yeah.
Maybe, yeah. Yeah. Anyway, so I just hope we can do this. And so, you know, we work together, but maybe now you've got a much more credible, capable author, and so maybe this is the time to get it over the.
You and I couldn't do it. It was like, right, but now we got Senator Maye Quade.
Get somebody else.
There's a fiscal note. Seriously, this is. I'm glad you're doing this one. You're requesting a fiscal note, right? I think it's going to be less than what everybody thinks it's going to be. Isn't that correct, Wayne?
It depends on how the calculation is done.
Yeah, and Senator Maye Quade, you'll keep us attuned to that. I think you want to lay this one over, and we might be able to do it this year. Then again, Senator?
Mr. Chair, we can't afford to save any money. I'm sorry.
Yeah. God, and here's your argument for dynamic scoring once again. I mean, here's another prime example. If we, the state of Minnesota, could do it for the seatbelt law, and there was one other one that they did it for, maybe it was the smoking. Thank you. Why can't we do it for this committee? Because we know this saves money. We knew that 5 years ago, but it was not booking against the savings, rather it was booking against the costs, Senator.
Mr. Chair, 33 states think it saves money. We'll see if MMB wants to agree. Thank you.
Oh, God. Thank you, Senator Maye Quade. Final words, you just want to, we're going to lay this over?
My testifiers said it all, Mr. Chair.
Yeah, they sure did. Thank you, Senator Maye Quade. Members are going to lay this one over, and now we're going to go to either Jim's or mine. You want to do mine real quick? They're going to be, mine are super fast, so, all right. Thank you. What's that? I love it. Is Nicole, is she online or is she coming? Oh, there she is.
Right now.
Come on.
Senator Hoffman.
Thank you, Madam Chair and members. Today, there's going to be two bills. The first one in front of you, Senate File 2651. It's aimed at improving the Min Choices assessment process on the timely and accountable and efficient services. We've all talked about, well, in one part, you can get it done in 2 days. The other part, it takes 60 days. Some it's 90 days, right? But there's a whole thing on Min Choices. Just met with some folks from Wright County, one of your members there, Mr. Freeman. But this one, it gets the conversation going, and there's some key reforms to address on this issue. And we know that there's some gaps in there, and that's why Matthew Freeman is up here too. We plan on continually working with him, Nicole. I mean, that's the thing we're going to do. But this, as you're looking at it, clarifies and strengthens the county timelines. That needs to be completed within 20 business days with financial penalties. So you're going to hear from Mr. Freeman about that one for noncompliance while recognizing the workforce challenges. We have a workforce challenge. We know that, right? The second thing is it creates a Min Choices team within DHS, providing the backup support for the hospitals and other facilities when counties cannot meet the 20-day deadline. This is a systems approach at it, folks, so let's do this. It expands the assessor workforce by adjusting the degree requirements and allowing hospitals to have certified assessors under specific circumstances. And finally, it establishes a new report to track assessments, backlogs, completion times, ensuring we have the data needed for future improvements. This bill, members, that we talk about is about accountability, efficiency, and ensuring the individuals aren't left waiting for the services they need. I want to turn it over to Nicole Helen, who's a social work manager for Children's of Minnesota. With that, Nicole.
Ms. Helen, welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Thank you, Chair and committee members. My name is Nicole Helland. I'm a social work manager at Children's Minnesota. I appreciate you having me here to express our support for Senate File 2651, which would help reduce barriers Minnesota children are facing as they board in hospitals across the state waiting to access appropriate mental health services. The children my team and I see in our hospital are some of the most vulnerable and high-risk kids in our community. We know these children need a level of care that a hospital simply cannot provide, and every day our team is working to partner with patients, their caregivers, and community providers to ensure that the children who are with us can safely transition to a setting where they have access to the mental and behavioral support that they need. Getting Min Choices assessments completed is one of the biggest barriers we face when trying to find placements for boarding patients with mental health needs. One of these patients, a 13-year-old, presented to our emergency department in November of 2024 in crisis. This patient would have extended stays in our emergency department, discharged, and returned to the ED multiple times while our team worked with our county partners to have a Min Choices assessment completed. Their assessment was finally completed this month, 4 months after they first came through our doors in need of support. Another patient, a 17-year-old, presented to our ED after running away from their youth shelter program. As we got to know this patient and better understood their history, we determined that they likely should have had the Min Choices assessment in place 5 years ago, but didn't receive an assessment until they were boarding in the hospital for 2 weeks. These patient stories are not unique, and these children deserve better. The bill before you would address key barriers that exist within the process of conducting these assessments by clarifying and adding accountability requirements for counties to meet current statute timelines. Creating a mid-choices team, a DHS can be deployed when demands on the system are too great for counties to handle on their own, and expanding the pool of mid-choices assessors so that hospitals and other entities can engage their own assessors as needed so as not to delay care. It would also require DHS to release a report twice a year that includes data that would help us all understand where backlogs in the system exist and inform future systems improvements. We look forward to continuing conversations with our county and DHS partners as this bill moves forward. Addressing these barriers is a critical step Minnesota must take if we want to address the crisis facing our kids. Improving this process will make a difference in the lives of the children we serve. Thank you, Senator Hoffman, for your leadership on this bill, and thank you, committee members, for your time.
Thank you. Mr. Freeman, welcome back. Please state your name for the record and proceed with your testimony.
Thank you, Mr. Chair and members. Matt Freeman, I'm the Executive Director of the Minnesota Association of County Social Service Administrators and a Human Service Policy Analyst for the Association of Minnesota Counties. Thanks for the opportunity to testify today on this bill and appreciate Chair Hoffman convening this conversation. Counties, we have concerns about some provisions in Senate File 2651. That said, MAXA counties, we have been in conversation with Children's Hospital and other hospital systems across the state, and we want the same outcome. Youth and adults receiving necessary medical care and then moving to the next setting with the right level of supports and services as quickly and efficiently as possible. County assessors balance the converging major processes, including medical assistance applications, disability determinations, provider capacity, and min-choices assessments to ultimately get to the supports a person needs. It's a fragile balance right now since every part of the system for people with disabilities depends on its experienced delays and workforce challenges right now. Measures such as financial penalties don't achieve our shared outcome and merely places a burden or a stress on a system on local taxpayers. Min-choice is important, but it's only one part of the county assessor, part of what the county assessor is managing. We do agree that data is an important element to inform current and future solutions. We'll continue discussions to refine that portion, and we do not oppose the concept of additional contracted or DHS assessors, but recognize that workforce continues to be a challenge across our broader system. So thank you for the work on this bill, Chair Hoffman, and counties will continue to work with stakeholders and you on this issue, and by bringing forth bills such as Senate File 2598, which you'll hear later today as well.
Senator Abeler.
Well, thanks. So if we don't hire any new people and don't penalize the counties, is there anything left of the bill? I don't want to penalize counties either, but is there any policy work here that's got merit, or is this just trying to create another off-ramp?
Mr. Freeman.
Mr. Chair and members, I think there is merit to exploring how can we bring additional folks into doing assessments. We need to balance some piece of that. There's also important information to gather and report on about how quickly these assessments are done and the capacity to do it. And I think, again, our focus is on that simplification process. How can we pare down what that broader assessment that isn't necessary, and appreciate you carrying that bill later, Senator Abeler.
In literature, that's called foreshadowing. Thank you.
Senator Hoffman. Any other member discussion?
This conversation went back collectively. You look at the committee members here, and we've had this conversation 6, 7, 8 years ago. In your packets is Children's Minnesota. There's a letter from Stephen DeLong, as well as look at the journey. This one, and those of us that were in the conversation 6 years ago, that's journey. Senators, I don't know if we really intended this system to be that complicated. So, because at the end of the day, it's why do we exist, what we do. So, I'm grateful that Matt's here. I introduced Nicole, and Luella there from Hennepin County is in the back of the audience, and we need to do something on this, right? And so, in how that looks, we'll be able to mark this up together as a committee. So, with that, thank you, and thank you, Nicole, and thank you, Matt, for being here. So.
Thank you. Senate File 2651 is laid over for possible inclusion in the omnibus. Senator Hoffman, you have Senate File 2750.
Nod, wink, wink. This is an exact copy, and you know what, Senators? I did not change the language on here so that different than the exact copy that we used this as a vehicle that the House, oops, I said that out loud. So maybe I would like to take an amendment to change it so it's one word or two words in here. Senators, that might be a little different than the House or the other body that's sitting over there in the House. We just need to move this to the floor where it'll sit perfectly, right, David? Yep.
Okay, so
Senator Abeler, you got a word, or Senator Rasmusson, or Senator Wickland, you're Senator Mohammed?
Senator Hoffman, I guess, yeah, is there anyone who wishes to make an amendment?
Well, no, we just don't want to make sure that the House version's identical to this. So is there some plan to, you can amend something on the floor.
We can just do it on, we'll do it on the floor?
Something clever,
I think
celebrate May Day
Mr.
or
Monahan
something.
might have an answer to that, Senator,
We'll go
Mr.
to
Chair.
Senate Counsel, Mr. Monahan.
Mr. Chair, members, the simplest thing to do would be to just move to delete section 2.
Done.
So Senator Hoffman moves to delete section 2 as an oral amendment. All those in favor say aye.
Aye.
All those opposed say no. The motion prevails and the oral amendment is adopted.
Thank you, Mr. Chair and members. I think now we go to Senator Abeler, right?
Senator Hoffman moves that Senate File 2750 as amended be recommended to pass and be put on general orders. Any discussion to the motion? All those in favor of the motion signify by saying aye.
Aye.
All those opposed say no.
He just yelled roll call.
The motion prevails, and Senate File 2750 is recommended to pass and is placed on general orders.
Thank you.
Thank you, Senator Hoffman.
Here you are.
Senator Abeler.
Well, thank you, Mr. Chair. Which one are you doing first?
We're going to do, it looks
2647.
like 2647 if you want, substance use disorder comprehensive assessment requirements, treatment provider qualifications, modifications. You got an A2 amendment.
Yeah, and I think there's a little controversy to this, but we'll work it out. So I'd like to move to A2 if I can.
Awesome. Members, the A2 amendment, all those in favor say aye. Aye. Opposed, same sign. Senator Abeler, now that the bill is in the form and the matter that you like.
Thank you. We're trying to make it simpler. Sometimes simple doesn't always make it easier for some people, but this is a work in progress, and I've got an amazing testifier. In the interest of time, I'll just let her do it.
You want to go to Sadie first, or Ashley, I think is on Zoom, or no? You guys want to talk to me?
I'm Sadie, I can go first.
You're going to go first. For the record, state your name,
Mr.
full
Chair, we have a
name.
bonus testifier here for the next bill. That's how efficient we're being.
I love
Right
this.
there.
You got Freeman on deck too. That's even better. So Sadie, for the record, give us your full name and I'll be quiet.
Sadie Brockmeyer.
And go ahead. Thank you.
My name is Sadie Brockmeyer, and I serve on the Board of Directors for the Minnesota Alliance of Rural Addiction Treatment Programs, or MERITAP. And I'm super excited. I happen to be in St. Paul today, so I got to come in person. Usually you see me on the screen. And we are a statewide association of rural residential and outpatient substance use disorder programs. I'm testifying today in support of Senate File 2647, as it would provide small rural SUD treatment programs flexibility in how we utilize our staff's professional competencies and make a small dent in the workforce shortages we experience in greater Minnesota. By way of context, in recent years, the state of Minnesota has made concerted effort to better align how we provide substance use disorder treatment with evolving clinical best practices as outlined by the American Society of Addiction Medicine, or ASAM. This has meant aligning our delivery of services with the ASAM level of care, including better recognizing the frequency of co-occurring mental health and substance use diagnoses. This has meant expanding the number of mental health clinicians in our program. However, for many small programs, these staff are not always being utilized to the fullest, and instead, the delivery of services are limited by the number of licensed drug and alcohol counselors we're able to recruit. Senate File 2647 would allow us to use our mental health staff to do comprehensive assessments like they might in other clinical locations, and in doing so, will free up our LADC's time to provide direct client care. One of the things that happened on Friday, we do walk-in substance use assessments at the clinic I work at in Mora, Minnesota. And I had to turn someone away for a walk-in assessment because we already had 3 other people come in. And so we didn't have a drug and alcohol counselor available. But I did have 2 mental health providers that were not able to do this, even though they are licensed by the state of Minnesota and able to diagnose substance use disorders. And so by supporting this and passing this, this allows for those 2 providers that I had available to be able to help somebody in need. And that is something that really highlights in rural Minnesota. Mayor Tapp appreciates all the work that's been done to go into this proposal over the last year, and I look forward to being able to be part of discussions as the session progresses. And I'm happy to answer any questions after the other testifiers.
Thank you, Senator Abeler. You got, I think, Ashley Jose. Is the K silent, or, correct me, please?
It is a CH sound, Chose.
Jose. Thank you. Well, welcome.
Thank you. Chair Hoffman, members of the committee, my name is Ashley Chose. I am the CEO of Woodland Centers. We are a certified community behavioral health clinic, CCBHC, that serves 7 rural counties in west central Minnesota. The legislation before you today is a result of over a year of collaboration and compromise across 3 associations to address the workforce shortages in the SUD treatment sector. And it really ensures that Minnesota statutes align with the national ASAM standards. In early 2024, Mayor Tapp and the Minnesota Association of Community Mental Health Programs, or MACMIP, drafted this bill, and we quickly engaged the Minnesota Association of Resources for Recovery and Chemical Health, or MARCH, as well as the Licensed Alcohol Drug Counselors, LADCs, for input. Anticipating this 2025 legislative session, leadership from all 3 organizations collaborated in the fall of 2024 to refine and reach a compromise on this proposal. In response to feedback from March's executive committee, the original bill, which allowed licensed mental health professionals to provide the full array of 245G services, was narrowed to focus solely on comprehensive assessments. As Minnesota adopts the ASAM-4 criteria, which is a person-centered model for substance use care, this bill aligns with its core principles. ASAM-4 does not limit SUD assessments solely to LADCs. Instead, it emphasizes comprehensive, multidimensional evaluations conducted by qualified clinicians within their scope of practice, which is exactly what this bill proposes. Imagine how many more Minnesotans we could serve if SUD assessments were available when people needed them, not just when the limited LADC workforce could accommodate them. Senate File 2647 is a crucial step towards making this a reality in Minnesota, and I urge you to support this bill and help to ensure that every person seeking SUD treatment in Minnesota has timely access to care. Thank you so much.
Thank you. Senator Abeler.
We'll take questions.
Yep. Members, questions?
They're on the edge of their seats, Mr. Chair.
Unbelievable.
So here's the deal. Yeah, I'll sum up. This bill still needs a little refinement. There's some work going on.
Oh, did you have, I'm sorry, Senator Abeler, was there an A2 amendment too that you should have done?
We adopted it, didn't we?
Did we adopt the A2? We did.
Oh.
Oh, okay, never
Right
mind.
on top of things, Mr. Chair.
You're on it. I
There's no
apologize.
A1, the 2 is,
The-
it tries harder.
Yep.
Anyway.
So go ahead.
So at the end of the day, there's not enough human beings to do all the work we need them to do.
Right.
And there's some people that are very qualified and capable in certain levels, and so this is the effort to find that level where we can have other people do some of the tasks of other credentialed persons that there's not enough of to go around. There's work going on, and assuming that this is going to be, hopefully we can just put this in our omnibus. Does this stay here, I think?
Yeah, I got it. Disposition is laid over, Jim.
There'll be an agreement that we're working to get, so that everybody's aware of that, and I think we're getting closer, so.
Awesome. Thank you for doing this work. So with that, members, Senate File 2647 is to be laid over possible inclusion in our omnibus bill. Jim, Senate File 2598, people receiving disability waiver services, abbreviated annual reassessments, authorization provisions. You got an A1 amendment, right?
I do. I'd like to move that if I can.
Members, the A1 amendment is in front of us. All those in favor say aye. Aye, opposed, same sign. Thank you very much. Senator Abeler, you got Katie Molinar.
There being one aye and no nay, Mr. Chair. So back to the flexibility, we mean it. Remember we sat around doing independence, we mean it, and
Oh my God, I remember that conversation.
yeah. And you know, the min choices, I wish that we would have brought this up before this year. This is, I think, my first mention of min choices, I think, in my professional capacity. That may not be true. Anyway, so
Oh, that was
the
funny.
assessment, Minnesota is required to have an assessment. It's not required to have the min choice assessment. And so-
assessment.
Yeah, so every year there has to be an assessment. And so we have discussed this many times. This bill is brought to me by the counties and others, hoping we can find some way to help serve the individuals who are backlogged. And so I'm not sure what benefit is, Mr. Chair, to have an assessment when it takes several months to get it while you're sitting waiting to go into whatever program, languishing. Anyway, and so I guess the department has ideas for technical assistance, but I'll listen to that. But Mr. Chair, the system is not working well, and that's not news to anybody, and I'm a fan of the department. So hopefully their technical advice will be how to make it even more streamlined, so we can focus our efforts on the people who really need the assessments. I believe each individual is allowed to opt in to get the full meal deal.
Yep.
Most people I've talked to would like to opt out for a decade. But so this is there's an assessment, and then 2 years with another less assessment, and then back to the track. So with that, I'll turn it my testifier, who's been just so on top of her game to be here even a bill early, which I think has never happened before. So thank you, Mr. Chair.
Katie from Ramsey County, you know, Jill Pooler from Wright County was here this morning, right? And we were talking about this specific thing, and your name and that woman's name in the back of the room from Hennepin County, Luella, can I say her name, was brought up about the work you all are doing, right? And specific to Senator Abeler. So I'm excited. An assessment, a reassessment. I live with something, I'm going to have that lived experience, that lived thing the rest of my life. Why do I have to go through? And the hours, I mean, I was blown away at how many hours, even on the reassessment, when, you know, there might have been somebody in this room who was the chair of this committee maybe 6 years ago who was told, you know, oh, that 8-hour reassessment is not going to happen in the future, but apparently that's true. So we look forward to what's going on. Please help us understand.
Mr. Chair, members of the committee, again, my name is Katie Molinaire, and I serve as a Social Services Deputy Director at Ramsey County, leading the Aging and Disability Services and Min-Choices Division. I'm here today on behalf of the Minnesota Association of County Social Services Administrators, or MACSA, and Ramsey County to testify in support of Senate File 2598. Thank you for having me. Many counties are experiencing increased demand for min-choices assessments for seniors and people with disabilities. Due to the current demand, many individuals must wait to be scheduled for their initial assessment, and more agencies are falling outside the statutory requirements for these assessments. This is a disservice to residents and puts additional pressure on staff. It's become clear the current system is unsustainable and changes are urgently needed. Reducing complexity and increasing efficiencies of the min-choices assessment is essential as needs continue to grow statewide. Residents are also asking for this. Building upon current statute, this bill will reduce unnecessary annual reassessments for case scenarios where the person's needs have not changed. As mentioned, it allows a shortened reassessment for 2 years in a row, followed by a full assessment the third year. It is limited to people between the ages of 22 to 64 who are on DD, CAC, CADI, BI waivers. And it still requires informed choice, and the individual can request the full assessment at any time. Allowing for shortened min-choices reassessment and related processes would better serve residents, decrease the amount of time needed per assessment, and therefore increase the number of people we're able to serve. We know there may need to be some adjustment to the language, and we're working with the department on technical assistance. This bill is urgently needed to allow counties to serve more residents in a timely, efficient, and effective manner. Again, thank you for your time, and I'm happy to answer any questions.
Thank you, members. Any questions for our good friend from Ramsey County? Seeing none, Senator Abeler, this conversation, it sounds like everybody's bringing you the technical assistance questions, conversations, et cetera. You're working on it, yeah?
Is the ARC going to testify or not?
No, David, you got no? I got no. Jim, all I got is Tina Rucci, who was, you know, she was, but she scratched it.
I just want to point out that Legal Aid and Minnesota Disability Law Center wrote a note saying they think this is a really good idea. So you have a lot of the planets lining up. And so one thing that's frustrating to me, Mr. Chair, is the last line. And for some reason, we think the feds have the right to mess with us on this. And I hope the approval takes about a minute. And so if we get snagged up, maybe we can talk to our 8 congressional people and 2 senators and have them expedite this approval so we can get down to the point of helping people. I want to remind you that Ramsey County just hired 80 people to do this with money they don't have, with people they cannot find. They're not going to find.
And I don't know how that happens, Senator Abeler, because like in Wright County alone, when I was talking to Jill Pooler, which is, I mean, the difference between Wright County, Hennepin County, and Ramsey County is completely, you know, you're ginacious, right? And they have the same capacity issue going on there, having 20 folks to do. I mean, it's just literally, is this how we wanted to set this up years ago when we said, I don't think so, Jim, right?
I don't think so, Mr. Chair. I wish we would have had bills to simplify and streamline along the way. So maybe this is the time. And if not, we should have Senator Maye Quade do it since she's moving other obstacles out of the way on the PACE program. So
I like that. I think you're onto something, Senator Eki. Senator Wickland, any comments? No?
That's all I got, Mr. Chair.
You're good. We're going to lay this over. Thank you, everybody, for hanging in there with us. Jim and team, we are going to I want to give you an update. Wednesday, most likely the second to last hearing before omnibus bill, unless we meet Friday 28th or Friday the 4/4, right? Any thoughts on that? If we want to extend, are we going to do it?
Not Friday.
No, not Friday. David, did you hear that? Not Friday. Utke, Wickland, nope, not Fridays. So this Wednesday, we'll hear more bills that were introduced on the floor earlier today. We do not have committee next Monday due to EID break. And then we'll keep everybody, David will keep everybody posted on updates Fridays in the omnibus. And then I just want to let everybody know, I have signed the governor's budget proposal jackets. And those will get dropped, I don't know, tomorrow. But I just want to let, I just signed them, so I don't want to.
Looking for co-authors?
Yes.
No.
See, I knew, why did I even bring that up, Melissa? I knew it was going to be, I signed them, the House signed them, so we're good to go. I signed them, and they'll be dropped, so now people can, there we go. We'll be forward. So thank you for hanging in there with us. You got work to do. We are adjourned.